Yeah, good evening from India.
Good evening from Dubai and a temperature of almost 45-degree temperature.
Oh.
I'm sure in the UK it must be cold right now.
It's indeed very cold. It's only about 20 degrees.
Yes.
Not too bad.
Much better than what we are suffering here in the heat.
Yeah. Well, I don't mind your heat.
Let's exchange for a few days.
Yeah, that is what I'm saying. He's the first person who don't mind heat.
Yeah, I know.
Ritu ma'am, you can go ahead. We are live on YouTube also now.
Okay. Namaskar and a very good evening to all of you. It's an honor and pleasure to welcome each one of you for being here in the Indo International Web Series 1 in association with RCOG Indian Liaison Group, a focused academic webinar on the basics of infertility. Renowned experts and speakers of the national and international repute will share the platform to discuss the challenges. And this has been meticulously conceptualized by our passionate masterminds, Dr. Lakshmi Shirakhande and Dr. Jyoti Malik, who have planned an exhaustive learning tour for us today to provide with very good practical tips as per the guidelines. And we are clubbed together here due to the combined efforts of our two energetic coordinators, our international coordinator, Dr. Jyotsna Pundir, who is a consultant gynecologist and specialist in reproductive medicine and minimal access surgery at St. Bartholomew's Hospital, London, UK, which is RCOG accredited Center for Training in Reproductive Medicine as sub-specialty fellow. And she's passionate about delivering safe, effective, and evidence-based medical care to the patients. She's very keen to educate, empower, and involve couples in decision-making in every aspect of the medical care. So thank you so much, Dr. Jyotsna. And we have our national coordinator, Dr. Sushma Verma, who is working as director, consultant at Sarvodaya Hospital Test Tube Baby Center, and also as consultant in Ayushman and Gayatri with interests in laparoscopy, infertility, pelvic surgeries, and high risk. So thank you so much, Dr. Jyotsna and Dr. Sushma, for bringing us all together here today. So over to Abhinav for the video.
Abhinav, समय का वीडियो चला दो.
Video.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा. वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
Ma'am, please unmute. Ritu ma'am, please unmute.
A minute. Yeah. So with all of us on this platform, it's an honor for me to introduce a stalwart with a great academic record, a very passionate personality, Dr. Lakshmi Shirakhande ma'am. She's the medical director, Shirakhande Fertility Clinic, Nagpur, the chairperson designate ICOG 2020, the national corresponding editor, Journal of OBGYN of India, Jogi, the national corresponding secretary, AMWI, senior vice president, Foxy 2012, the founder, patron, and president ISOPA Vidarbha chapter, a recipient of so many awards, publications, 20 national, 11 international, and has also done a lot of social work, sensitized 2 lakh boys and girls on adolescent health issues. Ma'am, we invite you for the welcome address.
Thank you. Thank you so much, Ritu. Good evening, one and all. I welcome our international faculties, Dr. Gulam Bahadur, who has joined us from UK, Dr. Anu Chawla, I don't know, I think she is having some network issues, Dr. Ruma, who has joined us from Dubai, all my national stalwarts, respected teachers, my seniors, and dear colleagues. This Indo International web series is planned with the sole aim of providing pure academics to those who are interested in updating their knowledge. We will cover all the important clinical topics related to obstetrics, gynecology, and infertility. We want to know the Indian perspective as well as what is going on in the Western world. So to provide the concept and knowledge about the East and West, this web series has been conceptualized, and I am happy that this first web series has been materialized, and henceforth we will be coming twice a month with important relevant topics to you all. So I don't want to come between you and the scientific deliberations. Once again, I invite you all for this first web series, and I hand over to Ritu for further proceedings. Ritu, unmute. Ritu, unmute.
Dr. Ritu, again you're muted.
Thank you so much, ma'am, for these enlightening words. And moving on to the scientific session, I would like to call upon the chairpersons for today's first session, and that's Dr. Rekha Rajendra Kumar, a very, very energetic and enthusiastic personality. She is a medical director, Miracle IVF Hospital and Chandana Hospital, Bangalore, Secretary, Bangalore Obstetric Gynec Society 2021, South Zone Coordinator for Foxy Infertility Committee, Chairperson Infertility and ART Committee, Kasoga 2022, 11 awards and 3 felicitations, and very, very energetic. Welcome to you, Dr. Rekha.
Thank you, Dr. Ritu. Thank you, Dr. Lakshmi Srikande, Madam, for giving me this opportunity. I'm happy to introduce Dr. Ruma Bhargava.
Yeah, just a minute. I'll just call the other chairperson, second chairperson.
Fine. Sorry.
We have the chairperson as Dr. Famida Banu, who's a senior consultant in minimally invasive surgeon, director of Femi Care Hospital, with fields of interest in laparoscopy, histoscopy, and high-risk obstetrics. And she conducts a lot of live surgical workshops and is also a postgraduate teacher for DNB, a very learned and with such a vast experience. Welcome to you, Dr. Famida ma'am.
Thank you very much. I will just put one statement. I would like to know how Dr. Lakshmi has this tremendous energy, and we are all addicted to these academics. So at home, children were saying, what, always you are interested in so many webinars. तो इसका जवाब मैंने ये देना चाह रही थी, सब एक चिराग के परवाने होना चाहते हैं, अजीब लोग हैं दीवाने होना चाहते हैं. तो एक ऐसा एडिक्शन है, we cannot say no to academics. Thank you, Lakshmi, for giving this opportunity.
Thank you so much, Famida ma'am. And now over to Dr. Rekha to introduce the speaker.
Thank you. I'm very happy to introduce Dr. Ruma Bhargava from Dubai here. An infertility evaluation is usually initiated after 1 year of regular unprotected sexual intercourse. However, the known risk factors for infertility such as endometriosis, PID, PCOS, obesity, reproductive tract malformation, etc. But the basic evaluation can be performed by an history-taking clinical examination like truncal obesity, hirsutism, galactoria, uterine malformation, etc. can be detected at the primary gynecologist level itself. However, to explain all this, we have Dr. Ruma Bhargava here. Dr. Ruma Bhargava Chakrabarti has passed her MD in obstetrics and gynecology from Grant Medical College and JJ Hospital, Mumbai. She has 25 years of post-MD experience in obstetrics and gynecology and in infertility, with 7 years in various hospitals in Mumbai and 4 years in Saudi Arabia. She has acquired training in infertility and IVF from Institute of Reproductive Medicine, Kolkata. She has acquired training in IVF and reproductive medicine from Homerton Hospital, London, UK. She's working in United Arab Emirates since last 15 years. She's currently working as specialist reproductive medicine and infertility at Conceive Gynecology and Fertility Hospital, Sharjah, which is a renowned IVF center in the Middle East, and in Panacea Hospital Center, Dubai. She is also the active member of ISAR, ASRM, and Aspire. Dr. Ruma Bhargava, thanks for coming here and gracing the occasion. We all are eagerly waiting to listen to you. Over to you.
Thank you. Thank you, everybody. Thank you, Lakshmi and Dr. Jyoti, for giving me this opportunity. And it is really a pleasure to be with my Indian and international counterparts. I shall now present my presentation. Just a minute. So my topic today is evaluation of female infertility, which is really a very basic topic, and most important part of an infertility management is the initial evaluation. If we do a proper evaluation, I think we can actually treat the patient much better. Approximately 85% of couples may be expected to achieve pregnancy within 12 months of regular and protected intercourse. Evaluation may be indicated for the remaining 15% only who find it difficult to conceive. A woman of reproductive age who has not conceived after 1 year of unprotected sexual intercourse in the absence of any known cause of infertility should be offered further clinical assessment and investigation along with her partner. Very important is along with her partner, because many times we keep on investigating the female and forget that there could be a male factor as well. Earlier referral for specialist consultation for further assessment and treatment may be advised when the woman is more than 35 years, or if there is any known clinical cause of infertility, or she has any history of predisposing factors of infertility, like endometriosis or any menstrual problems. These are the main causes of infertility. So we can see that the major part of the cause is female causes. 34% is only the male causes. Out of the female causes, 29% belong to the hormonal cause, 23% belongs to the tubal factor, 11% uterine factor, and 3% cervical factor of infertility. However, multiple relatively minor abnormalities, either with one or both partner, can account for 30% of all the causes. Very, very important part of evaluation is the history taking. We must allow sufficient time to obtain a comprehensive medical, reproductive, and a family history of the patient. The relevant history should include the duration of infertility. Now, in duration, sometimes we see that the patient is married for 5 years, but she is only staying with the husband for the last 1 year. So it's very important to know how much time she is in contact with her male partner. The menstrual history, that is the age at menarche, her cycle length, any volumina she has, any history of dysmenorrhea, which can maybe point to an endometriosis. Pregnancy history, if she has any children before, her gravity, her parity, any previous pregnancy outcomes, like if she has had any history of ectopic pregnancy, any complications of pregnancy, like if she has had any gestational diabetes, any preeclampsia, any postpartum hemorrhage, then that is important. Any previous methods of contraception, especially IUCD, because then this can point to a pelvic inflammatory disease later. Her coital frequency and any sexual dysfunction like dyspareunia, again, which can point to endometriosis. If she's using any lubricant, because sometimes this lubricant have got spermicidal property and that can come in the way. If she has any past surgical history, like any history of fibroid surgery, any history of endometriotic surgery, any overzealous ovarian drilling, which could have been done before, any previous history of pelvic inflammatory diseases or sexually transmitted diseases, and in India, most important, tuberculosis. Any medical disorders like thyroid, galactorrhea, hirsutism, etc. Any history of previous abnormal pap smear and any treatment she has taken for this abnormal pap smear. Any family history of birth defects, which can show some genetic causes, or any history of early menopause, which can predict a premature ovarian failure. If she's on any current medications and if she has any allergies to any medications, her occupational history and any exposure to any hazardous substances, and if she is using any tobacco, alcohol, illicit drugs. Nowadays, smoking is very common and a fashion among the young patients. So it's very important today to take the history of smoking, because we know that smoking causes the number of eggs to become less. Renee Lerick has said, listen to your patients. They are giving you the diagnosis, which is very true. If we take a proper history, most of the time we have a presumptive diagnosis in the beginning itself. So from the history, we can identify these risk factors. If she's giving history of irregular menses, ovulatory dysfunction, if she has any history of IUCD or tubal pregnancy or PID, then we can think of tubal factor. If there's history of dysmenorrhea, dyspareunia, we can think of endometriosis. Any cryosurgery, conization, leaf surgery on the cervix can lead to a cervical factor. Any history of ovarian cyst or endometrioma removal, any ovarian drilling, again, can lead to decreased ovarian reserve. Any history of previous fertility treatment, this is very important. If she has taken any IVF treatment or IUI treatment, the drugs that she has taken, the dosage that she has taken, what outcome has come out of it, all this history is very important for us to further deal with the patient. Then comes the physical examination. The weight of the patient and BMI is very important. A lot of patients today have polycystic ovarian disease and are suffering from obesity. Her pulse, blood pressure, and other vitals. If there is any signs of thyroid enlargement, breast evaluation for secretion to rule out hyperprolactinemia, any signs of androgen excess like facial hair, acne, in cases especially of polycystic ovarian disease, any vaginal or cervical discharge, any pelvic or abdominal masses or tenderness to rule out pelvic inflammatory disease, the uterine size, shape, mobility, and any adnexal masses or tenderness. Diagnostic evaluation should be conducted in a systematic and a cost-effective manner with initial emphasis on the least invasive methods. So first, we should not directly go to a laparoscopy or hysteroscopy. We have to first do the basic tests, and then only if required, we should go to the more invasive and expensive methods. Evaluation should also take into account the patient age, the duration of infertility, and the unique features of medical history and physical examination. First, we will see the ovulatory function, because this is the most common cause of infertility. So this accounts for almost 40% of infertility in women. The common symptoms, as we know, are oligomenorrhea and amenorrhea. The common causes are polycystic ovarian disease, obesity, thyroid disorders, and hyperprolactinemia. However, in patients with oligomenorrhea and amenorrhea, we do not need any specific tests to establish an ovulation. Menstrual history can actually predict 97.7% of the ovulatory factor. Basal body temperature, it is usually the ovulatory cycles are associated with a biphasic pattern. However, it cannot reliably define the time of ovulation, so no longer used. Mid-luteal progesterone more than 3 nanograms also predicts ovulation. However, it is not always on day 21. It will depend on the cycle length of the patient, could be 7 to 8 days post-ovulation or 1 week before the expected menses. It is a presumptive but a reliable sign of ovulation. Then we have these ovulation prediction kits, which identifies LH surge 1 to 2 days before ovulation. should be done midday or late afternoon, and we should advise the coitus on the next 2 days of the surge. Sonography in infertility, transvaginal ultrasonography, one of the most indispensable investigation in female infertility. It is a primary examination parallel to almost a clinical assessment, as it gives much more information than any other single test, and most important, it's non-invasive. So first, what we need to do is a baseline scan. We can predict a lot of things from this baseline scan, which is done on the day 2 to 3 of the cycle. Here we see that both ovaries should not be having any active follicles in terms of any functional ovarian cyst if it is present. Usually the endometrium is thin at that time. We can assess any pelvic pathology at this time. We can determine the ovarian reserve by doing the antral follicular count. We can assess the uterine cavity configuration. We can assess any downregulation which is present in an agonist cycle. And we can also predict the response to stimulation from this baseline scan. Then there is a scan which we can do at around day 8 to day 12, which will give us information about the uterus, about the dimension, the endometrial thickness, any abnormality like any anomalies or tumors, ovaries, the position, mobility, volume, the follicles, any polycystic ovary it is present, any cysts or tumors if present. The tubes, we can see the patency of the tubes at this time, or we can also see the hydrosalpinx at this time, and any free fluid in the pelvis or any mass present. So these are some of the ultrasound pictures. This is a triple line, very nice endometrium, which is present in the mid-cycle. This is a polycystic ovary. We can see all these small follicles present in the periphery of the ovary. This is a fibroid again, which is seen almost encroaching into the endometrial cavity. This is an endometrioma of the ovary. It is a polycystic ovary along with an endometrioma. This is an endometrial polyp, which is seen inside the uterine cavity. This is a hydrosalpinx. We can typically see that hostrations present, and this is mostly seen in the mid-cycle when there is more cervical mucus present. This is a typical film of pelvic adhesion. So when we are doing an ultrasound, if there's adhesion present, we can actually see these bands flapping around that area. And these patients, we know then maybe there is a problem and we can probably advise them an IVF. This is an intrauterine adhesion. Maybe she's had an MTP before or an IUCD, and you can see the whole cavity is full of adhesions present. Next is folliculometry, wherein we see the follicles from the day 10 and try to see when the follicle is around 18, if it is ovulating or no. Transvaginal ultrasound will reveal the size and the number of developing follicles and also provide the presumptive evidence of ovulation. A progressive follicular growth, sudden collapse of the pre-ovulatory follicle, internal echoes with this, the corpus luteum, and an increase in the cul-de-sac fluid will all suggest an ovulation. Other tests for ovulation, one is the other tests which should be done are TSH and prolactin, which will identify the thyroid disorders and hyperprolactinemia. A thyroid TSH should be more than 2.5, and it should be treated specially if the patient is positive for antithyroid antibodies. So for all patients, if we can do the antithyroid antibodies, if it is high, we can think of subclinical hypothyroidism and treat them. Prolactin should always be tested on a morning follicular phase sample because it will fluctuate throughout the day. Serum testosterone, DHSO4, and 17-hydroxyprogesterone can be tested in patients with signs and symptoms of hyperandrogenism. Insulin resistance tests, fasting blood sugar, HbA1c should be measured in polycystic patient in order to rule out glucose intolerance. T2 FSH and estradiol in women with amenorrhea. This will distinguish between the women with ovarian failure who will have a high FSH and low estradiol from those who have an hypothalamic amenorrhea. They will have a low or a normal FSH with a low estradiol. If FSH is more than 10 and estradiol is more than 70 picogram, then we can conclude that the woman probably has low ovarian reserve. Usually, the Day2 FSH and estradiol is used for women over 40 years of age, or in younger women with history of premature ovarian failure, or if there have been previous ovarian surgeries, or if she has a short menstrual cycle. Endometrial biopsy. This was used to demonstrate secretory endometrium showing ovulation. It was long considered a gold standard for diagnosis of luteal phase defect, But nowadays, studies have shown that it lacks precision and it cannot distinguish a fertile from an infertile woman. So it is no longer recommended for evaluation of ovulation or luteal function. Ovarian reserve. This describes the reproductive potential as a function of the number and quality of oocytes. Diminished ovarian reserve describes the woman whose response to ovarian stimulation is reduced. So in patient with DOR, high day 3 FSH more than 10 to 20 have been associated with poor ovarian stimulation. Normal basal FSH with elevated estradiol in early follicular phase is associated with poor response, increased IVF cancellation, and low pregnancy rates. Antral follicle count. I feel antral follicle count gives a lot of information about the patient's ovarian reserve. In fact, I trust the antral follicular count more than the anti-Mullerian hormone. AFC is the sum of the antral follicles, 2 to 10 millimeter on both the ovaries. Low AFC is considered to be 3 to 6 total antral follicles and is associated with poor response to stimulation, while antral follicle count has good intercycle reliability. Reproducibility may be limited in experienced hands. This is increased in women with polycystic ovarian disease. So these are the antral follicle. We can see this is having more antral follicles, probably a polycystic ovarian case, whereas the other ovary has got a low antral follicle count. Anti-Mullerian hormone, this is produced by granulosa cells of early follicles, and it remains consistent within and between the menstrual cycle. IMH level can be obtained on any day of the menses. It is 1 to 3 nanograms per milliliter. Low AMH levels of less than 1 nanogram per milliliter have been associated with poor responses to stimulation, poor embryo quality, and poor pregnancy outcome. In polycystic ovarian disease, AMH levels are usually 2 to 3-fold higher. Now we come to the cervical factor. Examination of cervical mucus may reveal chronic cervicitis. Postcoital test, which detects the presence of motile sperms in the cervical mucus within hours of intercourse, used to be done before for cervical factor, but it is no longer recommended because it is subjective, it has poor reproducibility, and does not predict inability to conceive. Tubal patency. It is important to ensure that the fallopian tubes are patent, especially if the patient has had previous surgeries like MTPs or DNCs or any interventions. HSG or HyCoSy may be able to establish the tubal patency. So this is an HSG film. This evaluates the patency, and it is performed between the 6th to 10th day of the menstrual cycle. It can document proximal and distal tubal occlusion, reveal tubal architectural details, and it can suggest fimbrial phimosis or peritubal adhesions by loculated or delayed spill. Proximal tubal obstruction require further evaluation to exclude artifacts which can happen due to tubal spasm. So usually we always give a painkiller to the patient and make her wait before doing the HSG. This is the HSG on the left side shows hydrosalpinx on both sides, and both the tubes are blocked. The upper right side, there is a fibroid which is seen encroaching from the fundal area into the uterus. The lower one is a normal HSG where both the tubes are patent and it is good. There's a good free spill present outside. HyCoSy. This is a transvaginal scan during which air and saline or a solution of D-galactose is infused into the uterine cavity and observed to flow along the fallopian tubes. It is a less invasive procedure, but it requires more expertise. The other advantage of HyCoSy is we can also see the proximity of the ovary to the tube. So we know that, if the egg is coming out from the ovary, whether the tube is able to pick it up or not. Laparoscopy and chromoperturbation with methylene blue solution can also demonstrate tubal patency or proximal and distal occlusion. It can also correct the fimbrial fibrosis or peritubal adhesion. Hysteroscopic tubal cannulation can also confirm or exclude any proximal tubal occlusion. Detection of antibody to Chlamydia trachomatis, this is more in the West, has been associated with tubal pathology. However, this has a limited utility. Next, we come to the uterine factor. The modalities which assess the uterine cavity are saline infusion sonohysterography, 3-dimensional sonography, hysterosalpingography, and hysteroscopy. The saline infusion is better. It better defines the size and the shape of the uterus cavity, and a high PPV of more than 90% for detection of intrauterine pathology like endometrial polyp, submucosal myoma, or synechiae. HSG will define the size and the shape of the uterine cavity and can also show developmental abnormalities like unicornuate uterus, septate, or bicornuate uterus. It has relatively low sensitivity in diagnostic endometrial polyps or submucous myoma. It cannot reliably differentiate between a septate or a bicornuate uterus. Evaluation will be done by pelvic MRI or a 3D ultrasound. So this is a picture where we can see the anomalies of the uterus in the ultrasound. We see a bicornuate uterus here. The next modality which can show uterine cavity is hysteroscopy. This is a definitive method of diagnosis and treatment of the intrauterine pathology. So when we are thinking of a hysteroscopy, we've already diagnosed that maybe there's a polyp, maybe there's a intrauterine adhesion. So we should always do the hysteroscopy not only for diagnosis, but also treating at the same time. Because it's a costly and an invasive procedure, it should be reserved for evaluation and treatment of the abnormalities, which is defined by ultrasound, HSG, or hypochy. Operative hysteroscopy can be used for polypectomy, removal of small submucous myoma, division of intrauterine adhesions, and resection of intrauterine septum. This is a polyp which is seen in a hysteroscopy. This is a hysteroscopy wherein intrauterine adhesions are seen. The other one shows a septate uterus. Next comes the role of laparoscopy. Laparoscopy role is very important in the evaluation of infertility. It is invasive and expensive procedure. So again, we should reserve the laparoscopy if we have found something and we want to treat it. Laparoscopy is indicated in women in whom endometriosis or pelvic adhesions or tubal disease is suspected based on history and physical examination. There is no randomized trials which have assessed the cost effectiveness of diagnostic laparoscopy in couples with unexplained infertility. So we should never do unnecessary diagnostic laparoscopy. This is an ovarian cyst which has been seen in the laparoscopy. The lower picture shows an adhesion between the omentum and the uterus in laparoscopy. Adhesiolysis is one of the procedures which is done. Myomectomy is another procedure which we can do with operative laparoscopy. Peritoneal factors like endometriosis and pelvic and adnexal adhesions may cause infertility. This should be considered especially in women with otherwise unexplained infertility. History and examination raises suspicion. The transvaginal sonography may reveal lesions like endometrioma. Laparoscopy with direct visualization of the pelvic anatomy is the only method of specific diagnosis of peritoneal factors. Now, the role of 3D ultrasound. I think three-dimensional ultrasound has made a real revolution in diagnosis of infertility. We can evaluate uterine shape abnormalities like Mullerian duct abnormalities, evaluation of uterine fibroid, especially the percentage of the submucous component in the fibroid and fibroid mapping, endometrial polyps, intrauterine adhesions, adenomyosis with the junctional zone. These are some of the 3D pictures we can see. It is almost as if we are seeing the uterus right in front of us. This is an endometrial polyp, which has been created in the 3D image. These are some of the Mullerian abnormalities, which are again seen in the 3D images. SonoABC, this is a 3D software with automated calculation and gives us good follicular count assessment. It is very, very useful for antral follicle count assessment, especially in IVF protocols. What is the role of color Doppler in infertility? Doppler is used to assess endometrial receptivity by seeing endometrial and subendometrial blood flow. 3D vascular indices like vascular index, flow index, and vascular flow index can help us to see the endometrium. This is the Applebaum scoring to assess the endometrial blood flow. So we have 1, 2, 3, 4, the 4 zones which are present. The positive findings in the uterine assessment is an endometrial thickness, which is 7 millimeter or more, a 5-line appearance of endometrium, blood flow within the zone 3 using color Doppler, myometrial contractions causing wave-like motion of the endometrium, uterine artery blood flow measured by the PI less than 0.3, myometrial blood flow seen on grayscale examination, and homogeneous myometrial echogenicity. If we find all these assessments, then we know that we are dealing with a good endometrium. The role of MRI in fertility. MRI is the best imaging modality for delineating the morphology and orientation of pelvic structures. It detects pathological lesions like endometriosis, adenomyosis, and leiomyoma, detects Mullerian duct abnormalities and ovarian pathologies. It also detects extrapelvic causes like pituitary adenoma when there is hyperprolactinemia, may be used as a problem-solving modality when sonography findings are inconclusive. Its limitation is that it is very expensive and it has a limited availability. Most important evaluation of all, I feel, is a psychological evaluation, because stress is often a very significant factor in infertile patients, especially in the females, because they are the ones who face the social stigma in infertility. Counseling is very important. Psychological counseling may be done either by the gynecologist or they can be referred to the mental health professional. A plan should be formulated about the evaluation and cost of investigations and treatment, and it should be properly discussed with the couple. In conclusion, the take-home message is that the evaluation of female infertility should include a comprehensive history and physical examination. Below the age of 35 years, we should evaluate if they have more than 1 year of unprotected intercourse. However, after 35 years, we can do it at 6 months. A woman should seek diagnostic evaluation immediately if she has any medical history significant for oligomenorrhea, amenorrhea, endometriosis, or any other condition limiting fertility. Diagnostic evaluation should include assessment of ovulatory function, uterine factor, patency of female reproductive tract. Ovarian reserve testing should not be performed routinely, but may be used in select women undergoing controlled ovarian stimulation. Routine laparoscopy should not be performed in the evaluation of infertile female unless there is strong suspicion of advanced endometriosis, tubular occlusive disease, or peritoneal factors. Postcoital test and endometrial biopsy should again not be performed as a part of routine diagnostic evaluation. It is important to remember that the couple may have multiple factors contributing to their infertility. Therefore, a complete initial evaluation is important to detect the specific cause of infertility for an effective treatment and success. Thank you.
Ruma Bhargava, congratulations. Such a vast topic you have beautifully summarized. One question I would like to ask, in Indian scenario, nowadays we see many women coming with premature ovarian failure and their AMH values are at the lower side of normal. What is your experience?
It is very correct, because one thing is smoking. Again, as I said, smoking is very common nowadays in the teenagers, and they don't understand that what they're doing to the ovary. Other than that, nowadays mobile radiation, again, electromagnetic radiation from the mobile has been also associated with low sperm count as well as low count in the ovaries. So it is true, nowadays we're having a lot of young women who's coming with less number of antral follicle count or AMH. But somehow I feel age is a very important factor. So these patients, if they're young, if we treat them, many of them do land up having conception. But it is the old women with low antral AFC, when they come to us, these are the patients who are more difficult to treat. And you are lucky in India that you've got donor eggs available, but here in Gulf countries, that is not available to us. So, you know, we have to struggle with these patients, and somehow that is where we are very happy when a young woman comes to us with a low AMH rather than an old woman.
Fertility potential, do you think across the continents it varies from woman to woman because of their genetic predisposition? Because in Middle East we used to say women had very large number of children, whereas here in our country 1 or 2 children, when the AMH values are less and they're getting premature ovarian failure. Nowadays very frequently we are seeing. So
actually, absolutely correct.
Dr. Lakshmi and any other senior doctors, they can contribute to the opinion, because Ruma, you are also working in Middle East. You may be seeing more number of children.
No, it is very correct. I think their food and their genetic thing, the Arab women are very, very fertile. And actually the low AMH is more seen in the Asian population here rather than in the Arabic population.
Yes. Even I used to feel even the Philippines, Bangladesh, all those countries also, the AMH values used to be very low compared to the Middle East women.
Exactly. You're absolutely correct, ma'am.
Ruma, you have done a very nicely presentation. I really appreciate. Thank you.
Thank you so much, ma'am.
Thank
Very
you
well
so
done, Dr. Ruma. You have covered all the aspects. Thank you for that session. Lovely
Thank you,
session.
ma'am.
Thank you.
Thank you, ma'am.
Thank you, Dr. Rama, for that excellent, informative, and such a lucid deliberation. And thank you to our chairpersons, Dr. Rekha and Dr. Famida,
Thank you.
for such giving us all your valuable input. It was a wonderful session, and we move on to the second session, and for which I invite the chairpersons, Dr. Sushma Verma, who is our national coordinator today, working as Director Consultant at Sarvodaya Hospital, Raipur, a former secretary of Raipur Menopause Society, and has got good organization skills. She organized 2 annual state conferences at Raipur, and interest in laparoscopic infertility and high-risk pregnancy. Welcome again, Dr. Sushma Verma.
Thank you, ma'am.
We also have as our chairperson, Dr. Tripura Sundari, who is presently working as head of department and consultant at Department of Obstetrics Gynec at KIMS Hospital, Minister Road, Secunderabad, formerly head of Department Obstetric Gynec, Gandhi Medical College, Secunderabad, authored many papers in journals like Indian Journal of Obstetrics and Gynecology, and a versatile speaker in many conferences, and inspector for Medical Council of India National Board, a great teacher, and a special mentor for the DNB students. Welcome to you, madam.
Thank you.
And now I hand over to the chairpersons, Dr. Sushma Verma, madam, to please introduce the speaker for today, Dr. Gulam Bahadur.
Thank you, ma'am. Thank you, Ritu Khanna, ma'am, for kind introduction and giving me the opportunity to talk in between such esteemed international and national faculties. Today, the incidence of infertility is rising day by day, and it is affecting almost 5 to 6% of the couples due to various factors, out of which 51% of infertility is due to male factors. So we are here to discuss about the evaluation of the male infertility. And to proceed in this program, I am going to invite Dr. Gulam Bahadur sir from UK. Welcome, sir. He is going to enlighten us about the evaluation of the male infertility. Dr. Gulam Bahadur is a past member of HEFA with wide interest, mainly involved in the andrology with a special emphasis on diagnostic analysis, male cancers and transgender patients, counseling, sperm freezing, etc. Dr. Gulam sir has published in BMJ Open 2020 on cost effectiveness, success and risk of IUI over the IVF. And Dr. Gulam's contribution to immunology and virology cell in 1986 provides the basis of COVID pandemic vaccines and with the first case of human ovarian tissue cryopreservation. Welcome, sir. And now I invite Dr. Gulam sir to enlighten us with his knowledge.
Well, Dr. Lakshmi, esteemed, I don't know whether you're.
He is logged in from 2 devices. I think so. Are you logged in from 2 devices, Dr. Gulam Bahadur?
Possibly not.
Because it's echoing your voice. Yeah. Now you are clear.
Are we okay now?
Yeah, you are clear.
Look, Dr. Lakshmi and esteemed panelists and guests, I'm really grateful for this invitation to speak about male factor investigation as it stands in 2021. For some reason, my screen is sticking. Am I sharing the screen with you?
Yeah, we can see your screen.
Okay, I'm going to share again.
Yeah, please make it slideshow.
Yeah.
Perfect.
Okay, so male factor, it is actually, when you think about it, and I think about it a lot, is that is the elephant in the room, as all the clinicians and everyone's sitting around, they're only looking at the female side, as if male factor has almost very little to do with the whole subject. And partly this is historical because of ICSI, and because ever since ICSI came about, male factor has almost been relegated, and we have really not spent much time to unravel what the issues are. And in fact, there are much bigger issues in terms of male factor, in that there's an increased risk of incidence of chronic medical conditions in infertile men, such as diabetes, renal heart disease, liver. And even if you look further down, you'll see combined with the, I'm trying to get rid of this shared screen panel. Okay, and I need to get rid of, it's occupying quite a bit of, okay, fine. That's wonderful. And on top of this, we're looking at the general health of men who become fathers through assisted reproductive technologies at a higher risk of, for example, prostate cancers, and a higher risk of testicular cancer. And certainly in this paper, where there's oligozoospermia based on concentration, whatever the hazard ratio is, it is much higher. And in this picture here, we find that the cancer development in men following infertility, where there's azoospermia, is actually, again, much, much higher. I'm still grappling because there's things appearing on my screen, which I wish would disappear so I can see my full slide. Okay. In fact, cancer risk in the first and second degree relatives of men with poor sperm quality also has an impact on second generation. Now, when we look at that, although the last speaker has shown us that only a third of the problem is due to male factor, in fact, as I said, it is almost half the problem is due to male factor, because when you consider what is unexplained infertility, and I think we really have to split unexplained, it's the only field in reproductive in medicine which seems to have a defined treatment when it comes to unexplained fertility. But we do need to unravel what unexplained infertility is. And here are the causes of male infertility. Again, more than a third of it is due to unexplained, and the other main causes are various, as shown here in this pie chart. Now, the areas that I wish to focus on are, I mean, we can look at the systemic pathologies such as diabetes, cancer, and now more recently the COVID infection. And in terms of environmental issue, you've got drugs, smoking, pollution, and now we need to add the COVID stress factors and what mental stress does. And believe you me, that even these stress factors have transgenital epigenetics, which can be transmitted on. And just to borrow this, that spermatogenesis is in the hypothalamic axis, as you can see, as the spermatogenesis drives. But when you have an external factor such as COVID infection, it is a respiratory virus. Although the second best place for it to sit in is the brain, and that will often affect the level of spermatogenesis, but it also causes oxidative stress. And whilst I'm on the subject of COVID here, I just want to show you that spermatogenesis is affected. In fact, you have far less numbers of far fewer sperms being formed post-infection. But if the Sertoli cells are affected, it may cause the breakage in the blood testis barrier, and you'll end up having antibodies present. And if Leydig cells are affected, you'll have hormonal alterations, possibly leading to hypogonadism. And these are the sperm before and after COVID infection, and you can see how the embryos that follow are. So why are sperm cells so interesting? Well, firstly, they're in very large numbers. And that is not a limiting factor, but each sperm is genetically unique in terms of, and that there's apparently no repair machinery. It relies on the oocyte to repair whatever DNA damage is done here. And so that here's your sperm. It's about 70 micrometers long. The nucleus contains 23 chromosomes, and the acrosomal side is what binds onto the oocyte, which is the fertilization, and the mid piece is the one that provides all the energy for the movement of the sperm. So in terms of spermatogenesis, we're talking about spermatogonia to spermatocytes to spermatogonia to spermatids and to the full spermatozoa here. But when we look at it very carefully, what I want to point out is that there's a lot more going on in terms of going from from diploid cells into the eventual haploid cells. And when we look at much closer to it, to what is going on, you can see all the genetic changes and molecular changes that are going on. The whole process becomes very complex. And if we drill further into the spermatogenesis, you can see that with each step, there is the acquiring what you call functional capability and all the various genes that are associated with it. Now, the reason why I want to show you this is that, again, I want to come back to what we call oxidative stress, that you throw the spanner in the works. Oxidative stress is and free radicals are probably one of the worst things that can happen in terms of the progress of the sperm, and it will define what the eventual sperm is. And so you want to begin repairing the sperm at a very early stage. And our nurse at the North Middlesex, she puts just about everyone on antioxidants, and I wouldn't put the patients on just any antioxidants because some are on such high concentrations that it will affect. It will have again a negative effect on it. So I want to take you on to some of the other stresses, the aging process, and with age comes more de novo mutations and more epigenetic alterations. So the number of the de novo mutations increase here. As if you look at the paternal age, going from 15 to 50, the chromosomal replications increase from 35 to 840 times all the various levels of changes that I have shown you in the very complex slide of spermatogenesis, so much so that you add some spanner in the works, such as a free radical, and you will have the chromosomal, how they come together, the cohesion will be affected. And so this is what we understand when aging processes occur, but it also means that if there's a poor lifestyle effect, then that too will also contribute to the damage of the eventual sperm, so much so that the male age does interfere with the embryo growth in IVF treatment. And you can see from here that the blastocyst numbers decrease with paternal age, and that there was a very significantly negative effect with the age on the characteristics of the embryos. Yeah. Also with age, we know that there's more diseases like achondroplasia, Apert syndrome, and a whole variety of these diseases here. And with age also comes that the offspring there's a higher incidence of schizophrenia and bipolar disorders here. So here are the de novo mutations with paternal age increasing right across. And when we try and understand what is happening, is that even miscarriages are associated with a paternal age. And we keep on blaming the age of the woman for miscarriages, but here we do have Cochrane review evidence where the age of the man is important. And when it comes to even working in an embryology laboratory, you'll find that the quality of embryo and implantation will suffer as a result of paternal age. Here's a scatter plot showing the adverse birth events by paternal age when you hold the maternal age group steady here. So I just want to now come back to what I've been asked to talk about, and that is the kind of nomenclature that we have. It's to the left, we use all these nomenclatures: oligozoospermia, asthenozoospermia, terator, a whole series of it. But these are all based on very old, parameters. Like if you think about what oligo is, it's less than 20 million. If we look at what terator is, less than 30% morphology. Well, these are from the very, very old standards here. And if we try and define what the various groups are, where normal sperm, again, they're trying to borrow here the 15 million, that's from the WHO's fifth standards. But at the same time, they forgot to mention that when you look at time, marry up what mild oligozoospermia is, that's between 10 and 20. So there's some very conflicting data here as to how this terminology is being used in terms of clinical practices, in terms of, so we stretch from normal to, the word crypto is also being used. So when we look at the cumulative pregnancy rates, so between 1 month and 6 months, there's absolutely no need to do a semen analysis. But after 12 months of trying, you do need to begin looking at that sperm analysis. And the problem we have is that we have a whole plethora of standards, and I have lived through many of these. In the old days, what, for example, normal morphology was something like 75%, and today it's 4%, by the fifth standard. And over the years, clinics have been selectively using whatever they want to offer the kind of treatment they want. Another one is, another good example is the antibody test. There was never any data. So in the older standard, they say, well, set whatever standards you want, and that is how it developed to the new standards at the fifth standard, fifth WHO manual, which puts it at something like 50%. Now, the problem is this is not based on any evidence here. My belief is that it is important to do the antibody test because that will give you a clue as to what the sperm sample really is like. Now, to the top left here, you can see how the standards have changed, and the WHO 2010 standards are here. Now, very soon, we are going to have the sixth World WHO standard, which I believe are not too different from the current standards that we are operating on. And virtually, I know for sure that virtually nobody is actually practicing the WHO 2010 standards, because in order to practice that, for most clinics, it would involve a lot of investments. And in fact, virtually, I know of very few clinics in the UK that are accredited to WHO standards here. we at Homerton are trying to achieve that. I mean, we do practice it, but we're just waiting for our inspection here. Now, in terms of sperm, you want to look at count, motility, morphology. But then what we do not see is the other side of things, that's a molecular level. And these are all what you call, what to the bottom side is what is evident, but on the top side is are all hidden abnormalities that which we do not see here whatsoever. Here's an example I've taken from a patient who brought his sperm analysis from another clinic, and I can pick this up for you right now. There's no name on the patient, so I'm safe, but the use of the word asthenoteratozoospermia is used straight away here, and it's only suitable for ICSI, it says. But when we look at the count and the motility, it's perfectly fine. There's no problem there. Below, I can't see because there's something that is occupying my screen now. And I can't seem to, maybe I should just move it, is that there's oligoasthenoteratozoospermia. This sperm sample is suitable for ICSI. Now, this word says that at least 3 parameters are off for the reference range. Well, let's have a look. Normal form, it says 2%. Well, I know full well that they do not do morphology using stain slides, and they do not count 400 sperm in order to achieve that. So they're literally picking out some of the data out of thin air, to be honest, in order to justify why patients should do ICSI here. Sorry, again, having moved this thing, it is sticking. My apologies. Okay, so here are the WHO current standards. I think what the 6th WHO standard will probably show is that the concentration will be 16. And I don't think anything changed. That's only because now I have to say something about the WHO standards. These are based on the couples who actually got pregnant. This is data derived from where pregnancy had occurred. You and I do not know what it is that when couples do not get pregnant. And this is why I think later on I'll explain to you that I introduced the concept of consecutive ejaculate, but I'll cover that in a few moments to come. So in terms of analysis, you're looking at the microscopic side of things, you're looking at volume. Sometimes the volume is very little, and so you have to think in terms of is the volume, where did the volume go? And you may need to look at retrograde ejaculation. pH is another one that we can look at. Sometimes it's acidic and very low volume. That will tell you that there's an absence of the vas. There's very little you can do about viscosity short of syringing it. And the kind of things that we can immediately measure is concentration, motility, morphology, agglutination, and the viability of sperm. Now, you don't need to do the viability of sperm in all cases. The only time I think it's necessary is where the motility is so low. Now, you can go for more advanced techniques by looking at the DNA fragmentation using comet or tunnel. You can look at reactive oxygen species. I think I'm really quite inspired these days by looking at all these new items, especially DNA fragmentation and the reactive oxygen species, because it is beginning. I used not to be a fan of this, but the more I think about it, the more I think that it is giving us a clue on the so-called unexplained infertility sector. There is no field in medicine that goes and treats unexplained by saying, here, I have a treatment called ICSI. I think we absolutely need to drill down on what the problem is here and to try and understand. And the other reason why we need to understand is that 70% of the women who will go through IVF will never have a baby. All right. Now, that may surprise you when I say that, given the claim and counterclaims that go on in clinics all around the world. When you go to a conference, you'll come back feeling that small. And the reason is that everyone in this world is achieving success rates that is that big, and you are just achieving that small success. And the truth of it is that nobody's achieving success rates that big. All right. These are all selected patients that you're looking at here. And this is the way that and we need to be more honest with patients and be able to tell patients that these are really what you can expect here. Now, this poor guy, he gave his life, I don't know what he did in his life, but he spent so many weeks masturbating. And if you look at the sperm quality, on one day he could be a sperm donor, and if you look in the orange section here, you will see that if the sperm analysis was done in that period of time, you would certainly classify him as a ICSI candidate, as an infertile or subfertile candidate. But you can see that individual variation of sperm is quite huge here. And perhaps the main area to focus on in terms of reproductive medicine is this red area that I'm showing you here, because that is where the real success rate and conception rates are being troublesome here. But I have been able to extend this to be on when it comes to, because we're looking at IVF type treatments, but I have also a great passion on IUI treatment and we can tweak the whole thing to try and fit the purpose here. So in terms of male infertility, you can look at the very local conditions, varicocele, genitourinary infections, epididymocarditis, and testicular trauma on the top here. You can look at the systemic conditions, diabetes, cancer, medications, infection. Now, cancer, I have it's a big passion of mine also, and I work with a lot of cancer patients and their environmental problems. And the last speaker mentioned about radiation and mobile phone effects too. Where it comes to now, at some point, some of the slides I have not assembled and in the right sequence, so I'll just have to pick and choose. Is that where there's oligoaciospermia, you do need to look for obstructive blockage here and make sure that there is no obstruction. And where there, and quite often these are also associated with cystic fibrosis patients, and you may need to do the CFTR analysis here. So a man in an infertile couple, you're going to look at the history, and you may look at the medical illness, medications, surgical interventions in the past. You may look at his sexual ability and the limitations, cryptorchidism, scrotal infection, testosterone, anabolic usage, lifestyle factors. You can consider obesity, smoking, and whatever supplements. And sometimes supplements, you absolutely need the right type of supplements. And I do support those companies who are investing in sperm semen analysis following their antioxidants. And I think that's probably the right way around. You can look at the physical condition. You can look at overall body nature, and that's obesity, molecular development, virilization. You can look at the testes. The testes size is quite important because it will also give you a very big clue on quite a lot of things. Such as the level of spermatogenesis. It could also give you a hormonal development side. And so I've already spoken about obstruction here. You can look at the varicocele and hydrocele. And when it comes to the semen analysis side of things, you can certainly do the semen analysis, hormonal assay, and you can also perform a variety of genetic analysis here. And just to remind you that you always need to do 2 semen analyses, at least 3 months apart here. And when it comes to I can't see some of the things, so I'm struggling here. Is that yeah? So when it comes to abnormal results, you want to. I have actually covered doing the kind of qualitative sperm analysis and so forth. But when it comes to testicular volumes, that gives you an important clue on the testicular and post-testicular defects that you may see, and you can enter into a whole cascade of genetic analysis here. So I'm going to skip some of these because they're too detailed and not what I wanted to show you today. But certainly where there's congenital abnormality, by absence of the vas deferens, you want to do test out for cystic fibrosis and counsel them, and you can do sperm retrieval procedures. Low volume, just make sure you check for retrograde ejaculation. And these are quite easy to do. We can discuss that later on. In terms of small volume testes side, you also want to look at the FSH. If it's low, you want to look at the issues of hypogonadotrophic hypogonadism. If it's high, you're probably looking at testicular failure, and you might want to be looking at in terms of sperm retrieval. But in terms of hypo, you can do LH, FSH replacement, and I have seen some fantastic results. But when spermatogenesis kicks up, it increases, but it does drop back again here. So in terms of pre-testicular areas, we are looking at hypog, diabetes, coital order disorders, erectile dysfunction, ejaculatory failure. And in terms of genetics, you can look at Klinefelter, the Klinefelter syndrome, immotile cilia, and quite a number of these congenital vascular immunological aspects here. In terms of obstructive side, I've also already covered that in terms of looking at cystic fibrosis. So to the left, you've got a whole set of cascades that show you what type of testicular problems exist in terms of systemic diseases. Again, we need to be careful that we are picking these up. And then also it is important to mention the testicular injuries here. In terms of elevated FSH and normal or low testosterone, you may interpret this as a primary testicular failure. If it's low FSH, low testosterone, you're looking at hypogonadotrophic gonadism. And normal FSH, we're looking at normal or primary testicular failure. Now, I'm going to have to skip quite a lot because I just have to say that there is absolutely no treatment when it comes to things. I mean, people have mentioned about using tamoxifen and clomiphene and gonadotrophins to kickstart spermatogenesis, but I really have not seen anything of this sort here. But I just want to very, very quickly come on to the andrology laboratory side. I think these need to be managed very well. You need to make sure that you are absolutely compliant with the 5th WHO standards. And to be honest, less than 10% of UK clinics are compliant as far as I can see. And you do need to use a Neubar counting chamber as opposed to a Maclet counting chamber. We need to have robust internal quality assurance system, internal quality control, and we do need to participate with external quality arrangement. You may see blood in semen, and I think this needs to be reported. You may see crystals in semen. This needs to be, and I know the last speaker sort of dismissed post-coital tests, but the more I think about it, sperm, this is the biggest, the most natural filtration process that is taking, that'll give you so much information. And I really do feel that maybe we do need to get back to looking at the post-coital test in a more meaningful way, because when they said that there was never any evidence to support it, well, because the IVF industry came in and said, well, there's no need for it because we will certainly it was irrelevant in terms of IVF. But when you come to trying to unravel a reason, and you have a duty of care to patients to explain what their problem is, then this is something that can be looked at. Abstinence, I just want to cover very quickly. I've introduced the concept of consecutive ejaculate, a sample being produced literally immediately after the first, which gives immensely important results. The motility, if on the right-hand side, if you see, is far, far better than the first one. In terms of the DNA fragmentation of the sperm, the second ejaculate, the one with the short after, is far better. So I think at this point, I am going to leave you with one thought only, is that we try and put so much with in terms of unexplained infertility, and yet we fail to try and understand what unexplained infertility is, purely because we have a great reliance on ICSI as the outcome. But I thank you very much for your time.
Very beautiful presentation, Dr. Gulam sir. It was a very detailed presentation which you have given. Thank you so much. But I was very happy about your thing about effect of age of the man, because people think even at 60, 70 they can have children. But it is many a time is after 40, the quality of sperm, as you said, comes down, and the amount of the missed abortions are very high. So the age has very good relationship. One thing I wanted to clarify from you, this criteria which they are saying, is it okay for normal pregnancy, natural pregnancy?
Sorry, I missed your question.
Hello?
Could you repeat it?
The strict criteria what they are giving, is it okay for a normal pregnancy? Natural pregnancy, I mean.
Yes, if you look at how the WHO's reference ranges are created, they're based on natural pregnancy. So technically, you know nothing about your subfertile group. Really, you don't know anything. And we're senselessly all trying to apply those standards as if this can be applied accurately to your subfertile population. And that cannot be right. And this is why when I've been practicing consecutive ejaculates since 1986 onwards, and it never occurred to me that it was something that needed publishing. But in later years, I did publish this, presented at ASHRAE, and we actually got and it's absolutely, and I'm grateful to Anil Goody because he has put it on his fertility courses and promoted it. And now many people in India actually use consecutive ejaculates as part of their routine management of subfertile couples.
Because it becomes difficult for us, for the patients, to convince them that they are having some defect, because always it's the female is less, they are not ready to accept, because the report comes below as normal. So it is difficult for us to manage or counsel the patient. That's why I was asking you. Thank you, sir. I thank you for giving me an opportunity to participate in this wonderful webinar. And the selection of the candidates are very good and presentation is very good. Thank you.
Thank you.
Thank you, sir, for such elaborate talk. Sir, I want to ask one question. How frequently you are advising DNA fragmentation test in your infertile male patients?
I think personally, I would like to see DNA fragmentation tests to be incorporated as part, but maybe not for all the patients, but where certainly those who are being considered for IVF, they should all be going through DNA fragmentation tests, because the kind of changes that I have seen, the level of DNA fragmentation becomes quite important when you consider that 70% of your IVF patients, and this is the HFEA data, I'm not talking about anyone's data, because 70% will never have a baby. Now, one of the things that I had introduced was that consecutive ejaculate. That consecutive ejaculate, the DNA fragmentation is far less. So whether you choose to do DNA fragmentation tests or just chance it and use that consecutive ejaculate for your IVF, I think you'll probably be way better off.
Thank you. Thank you.
Sir, and when do you recommend the semen cultures to be done for which patients?
Yeah, it's a very important question. Seminal fluid does have antimicrobial properties too. Whenever they've tried to culture semen, they have absolutely grown nothing, and it is very difficult for the microbiologist to try and grow things from semen, and whatever result you had will be misleading. The second thing is that if you think you're going to give antibiotics to try and repair that, or try to, it really is a non-starter. It's a waste of time.
Thank you so much.
But what you will see associated with the seminal fluid is a lot of white blood cells,
Right.
and those are the most damaging things, because those white blood cells will really produce a lot of the free radicals, and that is what is the most damaging aspect. And I suspect that it is also damaging the oocyte. I mean, not from the man, but even within the female. It is. I don't know whether you followed any of my talk at ESHRE, because that was reported in the newspaper last week, where I spoke on 1.6 million oocytes that were retrieved and what happened to it. And I spoke extensively on the competence of the oocyte here. And what was clear to me, that even women needed to have antioxidants in order to buffer themselves against the loss of competence through free radical attack.
Sir, do you also calculate anti-sperm antibodies, sir? How frequently? Both male or female?
Sorry, the question is, do we measure it?
Should we measure anti-sperm antibodies in the male and the female?
Absolutely, I do believe in it. And we used to, in the old days, we used to do the Kibrick test, which used to be, we took the blood serum and we ran the test, and it was extraordinary because some women were positive on anti-sperm antibodies. Now we can talk about this another day as a separate topic, but the fact that it was there really begins to underline what you want to achieve in life for the couple is a natural pregnancy if you can. And so as doctors, you have a duty of care to try and unravel what their problem is, not to just simply offer them ICSI. That is okay. If that is the last resort, then I think that is fine. But but before that, you have to try and do IUI, and we have amazingly good results. And many people told us IUI does not work. Well, I have been fighting the NICE guidelines for so long now, and I know that it works. We can get 33% of our women pregnant the RUI program, I know IVF clinics are getting 27% of the women pregnant. So we actually are succeeding in a way that no others are. But the thing is, there's nothing magical about what we're doing. We're just doing things methodically and going forward. And I think if you look at Anil Goody's site, I have spoken extensively on how you can improve your RUI success rates. And it's something that your listeners will be able to follow up.
Thank you.
Thank you so much, sir. I think it was simply fantastic, elaborate, informative presentation, and we thoroughly enjoyed. Yeah, and so we thoroughly enjoyed it. I think it would have gone for hours. We wouldn't have been exhaustive even after that. Thank you so much, sir, once again for being with us in India today. And thank you also, Dr. Sushma and Dr. Sundari ma'am, for your valuable inputs and for all your experience sharing. And so we now, thank you, ma'am.
Thank you very much.
And now we'll move on to another awaited scientific session, and that's the panel, being moderated by two of our dynamic moderators. And it's always an honor for me to introduce who really needs no introduction, and that's Dr. Lakshmi Shirikhande, a great teacher, loving, and a very passionate personality. And also privileged to introduce dedicated, humble Dr. Jyoti Malik, who is a great academician and a very charming personality. She is the Medical Superintendent, JJ Institute of Medical Sciences, Bahadurgarh, Director, Roots IVF and Fertility Institute, JJIMS, and Secretary, Haryana Association of Registered Obstetrician Gynecologists. A lot of special awards and achievements, awarded Six Sigma Healthcare Excellence Award and Healthcare Entrepreneur of the Year 2017, and also the Nari Shakti Samman, both international national publications, and invited faculty in a lot of national and local conferences. And welcome to you, Dr. Jyoti. Also, we have with us an international expert whom we love to listen to always, and that's Dr. Anu Chawla, specialist in reproductive medicine, St. Bartholomew's Hospital, London, a visiting consultant, New Delhi, member Infertility Committee of FOXI, Office Bearer of Delhi ISAR, and on board of international editors, International Journal of Human Reproduction, Research Development, and also the International Journal of Fertility Sterility, Bangladesh. She is chairperson to various infertility committees and also very learned and a humble personality. Welcome to you, Dr. Anu Chawla. And also we have with us learned panelist and good friend of ours, Dr. Manoj Chillani, chairperson-elect Chhattisgarh ISAR, past president Raipur Obstetric Gynec Society, president Indian Menopausal Society Raipur, recipient of a Global Health Care Excellence Award, and inked in Golden Book of World Record for maximum number of embryo transfers. Very vibrant and courteous. Welcome, Dr. Manoj Chillani. Next, we have Dr. Mangala Kawade, who is a consultant gynecologist, IVF specialist, laparoscopic and hysteroscopic surgeon, honorary IVF consultant and Cherayu Medical College and Hospital, Bhopal, the vice president of Bhopal Obstetric Gynec Society, presented papers and posters in national conferences, and pioneering establishing the first IVF center of Bhopal in 2001. Very loving, caring, and really determined. Welcome, Dr. Mangala. Also, we have Dr. Arun Rathi, who's presently working as Chief Director of Siddhi Vinayak Laparoscopy and IVF Center, Akola, trained in endoscopy at Beams, clinical fellowship in advanced gynec endoscopy at France, and also at UK. Very energetic and very meticulous. Welcome, Dr. Arun Rathi. Dr. Arun Barwa is a consultant gynecologist, Sampriti Hospital, Sivasagar, Assam, chairperson, Northeast ISAR and chapter IAGE, president, Dibrugarh Obstetric Gynec Society, vice president, SOFSI, published 9 chapters in textbook and recent advances, and also publication in national, international journals, and faculty to various national, international congresses. Also, very, very dedicated and passionate. Welcome, Dr. Arun Barwa. We have Dr. Shaili Agarwal, the Associated Professor of Obstetric Gynec GSVM Medical College Kanpur, the Joint Secretary Kanpur Obstetric Gynec Society, the convener Basket for Beginners Workshop AICOG 2020 with special interest in high-risk emergency obstetrics and menopausal health, more than 30 national international journal publications, very humble and very pious. Welcome, Dr. Shaili Agarwal. Dr. Himangi Agarwal, consultant obstetrician and gynecologist, Siliguri, West Bengal, worked as senior resident in Department of OBGYN at North Bengal Medical College and Hospital, Siliguri, participated as a faculty and coordinator in the East Zone Yuva Foxy 2021, held very shortly. She's very, very energetic and always a helping hand. Welcome, Dr. Himangi. And with all our experts and panelists on board, I hand over to my dynamic moderators, Dr. Lakshmi and Dr. Jyoti. Over to you, ma'am.
Thank you. Thank you so much, Ritu, for wonderfully managing the show. Friends, this is a panel discussion where we have not prepared any PowerPoint. It will be a pure discussion. I know many points have been covered by Dr. Ruma and Dr. Gulam Bahadur, because the idea was to cover the whole of basics of infertility, because that is practiced by each and every gynecologist across India, and it is useful more so for our colleagues, those who practice in rural parts and they don't have any advanced facilities to fall back on. So that is why emphasis on the basics, and we have already learned basics of female and male evaluation. Now let us go towards the case-based discussion. So first, I will be covering 2 cases on male infertility, which will be followed by 2 cases on female infertility by Dr. Jyoti. I request all the panelists to be very crisp and please don't repeat the answers and no theory, as we are interested in giving practical tips to all our clinicians. So here we go. The female part is normal. This is a 28-year-old male has come to your OPD with a report of azoospermia. What next? Manoj?
Madam, when patient visits to me with azoospermia, I would like to first repeat the test also. It depends, like sometimes there are false reports also, because the treatment and advice will definitely affect him a lot. So first and foremost, I'll repeat the semen analysis. Then I will take the history from him, any history of injury and other things, any exposure to chemicals, where he's working, what is.
Manoj, we will come to history taking. Here I just wanted everyone to not jump to the diagnosis just because he has produced one report of azoospermia. Please, it can be a temporary azoospermia. He must have suffered some viral infection in the recent past. And that is why when he gave sample, it is a azoospermia. So it is your responsibility as a treating clinician now to please repeat the sample, instruct the lab to centrifuge the sample and see for sperms in that centrifuge sample, because labeling any man with a azoospermia is a very, very big thing. So before labeling him as a azoospermia, please very cautious, repeat the test, centrifuge the sample, and then only the. Now you have confirmed the azoospermia. Himangi, I am coming to you because you are from Siliguri. Will you manage yourself or will you refer to andrologist? Do you have that privilege, I mean the facility? Andrologist at your place? Unmute yourself, Himangi. Yeah.
Yes, ma'am. Ma'am, first of all, I would like to take the history at least, history
No,
part.
will you refer or
for
will
the
you manage?
examination?
Azoospermia.
Ma'am, I would refer him to a urologist.
Okay.
Because the andrologist is not available at our center.
All urologists are andrologists. Their degree mentions urologist and andrology. Yeah, I'm not joking. I mean, by default, all urologists are andrologists. Yeah.
Yes, ma'am.
But not ready to go. You have to manage. So now let us go. As a gynecologist, you are managing Arun. Dr. Gulam Bahadur has covered, practically speaking, all the points. But can you just summarize for the benefit of our audience? the crisp, relevant points you will ask in history taking, not all the points, in a patient of azoospermia?
The history part, like, is there any history of any infections? Like the most commonest in our area is mumps, history of tuberculosis, like for the infection part, any history of trauma or any surgery like hydrocele hernia, which deals with scrotal, because that can cause injury to the ejaculatory duct part, which can lead to obstruction. So primarily I am looking at in the history, I'm trying to click on whether it is obstructive azoospermia or a non-obstructive azoospermia. So grossly, I will look at the constitution of a male, whether he has a look of any something like Klinefelter. How is his beard? Is he shaving regularly? Does he has hairs on his chest? So all these things will give me about some clue about his hormonal milieu of his body. And on this history, I will try to differentiate whether it is going in favor of obstructive or a non-obstructive. Then the role of examination comes, wherein gross examination will have the features of the androgen features like beard, chest, hair, and everything. On local examination, how much is the volume of the testes? Am I able to feel the vas, or there is absence of vas? Then volume of the testes is vital. The consistency is vital. Is there any evidence of varicocele? Because all these things will rule out one or the other causes which are responsible for azoospermia.
Yeah. So I know both the Aruns here can examine the male patients, but whether Shaili and Himangi are comfortable with examining the male patient? Shaili, what is your say? Here.
No, ma'am, we are not comfortable. We will refer to Dr. Arun.
Thank you so much, ma'am.
Now let us come to Arun Barua. Arun Patti has told you about the history, the examination. Basically, he is very right that history and examination will tell you so many things that you don't have to do unnecessary investigation. So what are the relevant investigations with which you will proceed further in a case of azoospermia?
The relevant investigations will actually be guided by the history from the patient.
Yes, very good.
All said and done, one important point my very good friend Arun has missed out is the history of smoking and the work atmosphere, whether the patient is exposed to heat or the chemicals, radiation, something like this is also equally important. And exposure to tobacco plays a very pivotal role. It may be very small in numbers in quite a few areas, but it plays a very important role. But going down to the investigation side, to the clinical examination, the most difficult part, as you said, only the males are being allowed to examine male. I don't agree to that.
Not allowed. We are not comfortable, Arun. That is what I am saying.
When we are the male gynecologist, we have to make ourselves comfortable to examine a female partner. I think the reciprocation lies on all the female gynecologists, my dear friends. So that barrier has to be broken apart. So once we break that, I think we can always do that, because the people come to the doctor based on her or his name. So they are ready to do anything that you really ask for. Okay. Now, basic examination that we'll try to look at is the volume of the testis. Initially, when you get the genital exposed, just ask the patient to give a cuff, but by turning his head to one side and see whether the scrotum gets lifted up or not. The other thing is that put your hands down with of course with the gloves on. You'll be able to feel the volume, the vas, and also if you're well acquainted, you can feel a good feel of the epididymis as well. Now, having done so, you'll be able to come to a conclusion. Volume से अपना हम लोग को interpretation करना है, vas से करना है, epididymis से करना है. Associately, whether there is a varicocele or not. See, today I think varicocele plays a very important role in male infertility, and I don't know how frequent it is in other parts of the country, but in our area where we are practicing, I find at least around 10 to 15% of my patients has varicocele as an important component of infertility. Okay.
Since you are on varicocele, does all varicocele they need surgery?
No, definitely not. I think the surgery can do more harm than doing anything good.
So, yeah, give this take-home message to the audience that you are finding varicocele, but not all varicocele they need surgery.
Exactly.
Yeah, please go ahead. Yeah, Arun.
And along with this clinical examination, we'll do some hormonal estimations, and by combining with the hormonal estimation with the volume of with the clinical examination, we'll try to level whether the patient has the possibility of a primary testicular failure, secondary testicular failure, or it's a normal thing, and we can give them some sort of hope based on this combined parameter only. So
Arun,
clinic.
will you do PR examination and why and what information you will get per rectal examination?
Our rectal examination is not done routinely in all male infertility patients, but when you fail to document any positive results, I think having your fingers put in a rectum and get a feel of the prostate is really very important, because the prostatic component of the semen also has a lot of final outcome of the sperm in their fertility potential.
Manoj, will you do any genetic studies, karyotype or Y sperm deletion or something? Manoj Chelani?
Yeah, ma'am, I'll do karyotyping for structure abnormalities and Y-chromosome microdeletion also. So to know whether there's any genetic abnormalities there.
Yes. And now coming back to Shaili. Shaili, can you just tell me in brief and to the point the management steps for non-obstructive azoospermia? What are the options for this male?
See, the non-obstructive can be the pretesticular or can be the testicular. In the pretesticular, then there's a hypogonadotropic hypogonadism. So in these cases, we can give the hormones, exogenous hormones, to induce the spermatogenesis. And in the testicular causes, we can do the the extraction of the semen sperms from the testis itself. So these are the options which can be given to these patients.
Yes, Himangi, can you tell the steps for obstructive azoospermia? Because I'm just trying to cover in a nutshell that what are the options in a non-obstructive and obstructive. So would you like to elaborate?
Ma'am,
In obstructive.
obstructive azoospermia, first of all, when the site of obstruction is confirmed, like epididymal obstruction by testicular biopsy or by vasography, then we can move for surgical sperm recovery and ICSI, like these microsurgical techniques, MISA, TISA, TC like things. And if there is a prior vasostomy, then we can go for microsurgical vasoepididymostomy also. Like these, once the site of obstruction is confirmed, then we can move for the surgical sperm recovery and then towards the ICSI procedure.
Yeah. Before going to the next case,
Yeah, madam, just want to have one
Arun,
point.
I am coming to you only. You just have to elaborate what is the role of IUI and ICSI when you would like to do IUI and when you would like to do ICSI in cases of azoospermia. Oligo is our second case, so we will come later. So just tell the audience your take on IUI and ICSI, TISA, PISA, whatever in azoospermia. Yes, Arun Ratli.
Yeah, first thing is just I want to put one point for the prior discussion, that whenever you have an azoospermia patient, and in that when you do gross examination and hormonal examination, roughly you are able to decide that this is an obstructive azoospermia and this is a non-obstructive azoospermia. Generally, they have hypospermatogenesis. So most of the times, in like almost 1/3 of the patients, they will have a patchy spermatogenesis, meaning thereby you may have azoospermia in 2 or 3 or 4 reports, but occasional semen sample will show some sperms. So this is very, very important, that when you are able to diagnose a non-obstructive azoospermia, wherein the testes were small, the FSH is either low or borderline high, even between 13 to 20, you must repeat at least 3 to 5 semen examination, proper semen examination, because by doing repeated examination, you are able to pick up few patients where if you do a proper pellet formation like you do at 3000 G centrifugation for 15 minutes, and if you look at the pellet where in dedicated labs, if you look at 1/3 of these patients are picked up where you can have sperms in the ejaculate and you can use these sperms for ICSI and you avoid the procedure of TSA. This is very, very vital because most of the time 1 or 2 reports and we label them that you have to go for actually TSA. Rather than that, if you do repeat 4, 5, 6 samples with proper centrifugation and a dedicated lab, where you demand the pathologists that kindly look for the sperms because they will be able to pick up that 1 or 2 sperms. This has been there. 1/3 of the patient will be saved of the surgical procedure. This is what I want to share. One thing.
Then Arun, this centrifugation and procedure should be done where IVF facilities and facilities of cryopreservation are available. If
yes,
they get report from standalone labs, then it is not beneficial to the patient because we will see only 1 or 2 sperms, but we have not done cryopreservation. So then I think we have to advise the patient to go to a facility where if they see the sperms, they can do cryopreservation.
That's something which is very ideal. It has to be done.
I mean, that is ideal for the couple. I mean, ideal
exactly
for
the patient, for the patient. But suppose some consultant is handling these couples. So rather than labeling them as azoospermia and then you don't have any hope, we can the consultant can definitely ask for repeat examinations and talk to the lab person that such patients will have somewhere like a patchy spermatogenesis and in 4, 5, 6 samples they will show some sperms which you can counsel that they can have their own biological child, and that would be a really positive thing for the couple. And then you can contact the your colleague consultant who's doing IVF practice having a freezing facility and they can have their own biological child. That would be, they will always.
Arun points, I just want to interrupt. Please, whenever you see any couple who comes to you with a natural child and the husband report is azoospermia, please don't do loose talk and don't jump to the conclusion. Arun has already told you that there can be patchy spermatogenesis and they can have their natural biological child. So miracles do happen. So please be judicious in what you are talking to them. Yes, Arun Barua wanted to comment. Yes.
One of the very important points in this azoospermia would be if the husband looks very muscular, they always take a history because that person might be taking a lot of steroids, going to gym, developing his muscles, and thereby producing an iatrogenic azoosperm.
Yes.
This is one very important cause today. All of the boys, young boys, they are very much interested in going to gyms and getting their muscles developed at any cost.
Yes. Arun, since here, can you tell the role of testicular biopsy also in cases of azoospermia?
No, I don't recommend testicular biopsy now because testicular biopsy, I think for last 20 years, we haven't done any till date. But because once you injure the testis, the immunology of the whole testicular system gets changed. So it is always better not to injure the testis just for the sake of making a diagnosis. Today we have enough parameters to diagnose the condition by biochemical investigation or even looking at the clinical examination or even by taking the help of an sonography. So that is.
I'd like to add to you, Arun Barua, that whenever if you feel like doing testicular biopsy again, please do it in an IVF lab where if we find the sperms in that sample, we can do cryopreservation and later on we can go ahead with the ICSI. Because just doing the repeat semen sample or the biopsy is not going to help that particular couple. So even if those facilities are not available to you, think of the patient and please refer them to a proper place, to a proper doctor. Yes, Arun Rathi, you wanted to say? Manoj?
Yes, as sir has rightly said that actually biopsy is not needed by investigation and clinical examination, because having sperm seen in a biopsy does not guarantee that you will have when you do a next, when you post this patient for TSA, and you will get sperms, because as I rightly discussed, shared, that it can be a patchy spermatogenesis, and it is not necessary that you will hit the same site to get the sperm. So when you do a sample, and if you are able to see sperms, always try to freeze them. And even freezing does not really promise that you will have the healthy motile sperms which you had preserved at the time of extraction will be the same. So you need to discuss these both things to the couple. And having said this, ART has been a wonderful thing for people, for the couple where obvious male factor is there. So as going to your question, madam, that patients who want to have their biological child having obstructive azoospermia or having congenital absence of both the vas, these are the patients who are almost likely to have active motile sperms, and they do very well, almost to the tune of success rate of 30 to 35% per cycle. And you can preserve these sperms and use for their future children, future babies also. For the non-obstructive cases, one needs to be very, very patient. You have to use you must have a dedicated team of andrologists to do micro TSA, wherein you map the testes, and you can take almost 16 to 18 small needle biopsies having 1 or 2 seminiferous tubules from all the sides, and look for the sperms. Usually the success rate is to the tune of almost 12 to 15% to harvest the sperms, and pregnancy to the tune of almost 15 to 18%.
Yeah. Now let us go back to our international expert, Dr. Anu. Are you with me? Now you have heard the Indian perspective. We would like to have your perspective, what you do at your place. Anu? Yeah. Unmute yourself. Yeah. Your take on the whole case of azoospermia, your take-home message for our participants.
Yeah, hi. Thank you very much. So, like very rightly pointed, that, first of all, beginning in the room, how we respond to the report of azoospermia is going to mean a lot. So that was a very, very good point, that if they already have a child, especially, that conversation itself should be very sensitive. And then next is that evaluation. Of course, repeat semen analysis has a very big place, and maybe not immediate, maybe after 6 to 8 weeks at least. And then depends on the place where we are. Are we in the IVF lab? Are we in the simple gynecology clinic? Or are we in an IVF lab which is having very modern facilities? Like, for example, rightly pointed by Dr. Arun Rati, that if we have occasional sperms, we can freeze them. And the new way of doing that, no one has it in UK, but some people have around the world. Started from Israel, I think, and a few units in India are already doing. Dr. Pai's unit is doing, that is sperm vitrification device. So with very, very few sperms, just repeatedly taking sperms and freezing them can actually solve the whole problem, because azoospermia is relevant as long as they have a child. After that, it's not relevant to the couple. And then place of surgery. So currently, I am in an NHS unit at present. I have also been in the private units in UK. So the way they manage it, the place of surgery is actually very different in the public and the private sector in this country, I'm sure anywhere in the world as well. So the place of surgery is pretty quick in NHS. So we do the surgical sperm retrieval here in this unit in cases of proven azoospermia. And that is the first step. But I totally agree with Dr. Arun Barua that we should always bear in mind
So here we have to address the public funding system, and their turn has come and we have to do something for them. So that also drives our decision making. But very rightly pointed by Dr. Barua that once we injure it, it is going to change the biochemistry inside the testis. So it is very important that we do it at a point when we know that this is the right stage. Before that, if it is a hypogonadism case, Dr. Rupin Shah was the person with whom I actually, in the beginning of my career, treated a few patients, and we had a very, very good outcome in which we did give HMG over the period of a few weeks, even up to 6 months to a few couples, and that helped a few patients. So in the case of when we see, obviously, when I see azoospermia, I would want to see the FSH and LH, and I would want to tell them about this. And then if it is after the whole journey, if we are at a stage of surgical sperm retrieval, then there is, of course, a role of surgical sperm retrieval to the extent of microtessay. Of course, microtessay is very, very extensive. So yes, we do surgical sperm retrieval in NHS units more readily as compared to private units here as well.
Yeah, thank you, Anu. I would like to go back to Himangi. Himangi, not all patients are affording for TISA, PC, TC. So what are the indications for IUI by donor insemination in cases of azoospermia? In which cases you will advise?
Donor insemination can be advised if the patients are not willing for ART itself. They are not choosing the option of ART. They just want to go for a donor insemination like that.
So Arun Rathi wants to say something. Arun Rathi. There are indications for donor inseminations because all patients, they can't afford TC, PC, and looking at the success rate in India, that is the problem because patient pays from their pocket. So, I mean, we have to give them options. I mean, all the options and let them choose. Yes, Arun Rathi.
Yes, madam. I mean, I fully agree with you as well as madam, because it's an informed choice by them, and depending upon their social, financial status, because child is an emotional need.
Yes.
So depending upon the situation, their social strata, they can choose, and we must encourage them to have so, because it's not wrong.
Yes.
It's just the way you counsel, because having a child, their entire body language, their attitude towards life changes, and they feel really on top of their happiness.
Yes, yes.
As Arun sir rightly said, proper counseling is very, very important. In this case, both the couples should be counseled properly, and they, even if you are going for a TSA and micro TSA, they should be prepared for a donor, and beforehand also we must do the proper counseling.
Yeah, Manoj, in my practice, because of the cost constraints, many patients are opting for IUI by donor insemination rather than going towards the TCPC. Because when you explain them the success rate and when you explain them the cost of TC versus IUI donor, I mean, in India, majority of the patient, they go towards it. So I would like to invite one take-home comment from all the panelists, and then I will hand over to Jyoti for the case on female infertility. Yes, Shelly, you are nodding.
There's a role of lifestyle modification also. Whenever we see a case of male infertility, we should take the history of cigarette smoking, which can be preventable. They can,
and not only active smoking, passive smoking.
Also the passive smoking also.
Hookah parlors are so famous. Pre-COVID, it was very popular.
Yes, it is very popular, and among the youngsters, it is also very popular. And another thing is the physical activity. We have to maintain an ideal BMI. So these two things from my side.
Yes, Manu Chelani.
Repeats and semen analysis is very important when a patient comes with the report of azoospermia. We should not rely on just one report, and we should definitely do again repeat the semen analysis. Then we can do the proper counseling.
Yes, Arun Rathi.
I always, like, whenever I talk to couple, there are certain 20-30% of the couple are in two minds because there is a financial constraint, want to have their biological child. So I encourage them that, this is your emotional read. Right now, you are having a financial constraint. So go for donor, earn some money and come back with your money for your own biological child. And that really motivates them to go ahead with donor IUI.
Yeah. Himangi, you want to give some?
We should always, ma'am, emotional state of the couple should always be kept in mind. And we should provoke them that there are various methods by which they can conceive. If not by the direct way, then donor insemination can always be given a trial.
Yes, Arun Barua, then I will come back again to Anu for final comments. Yes, Arun.
My take is whenever these patients come to your clinic, spend sufficient time with them. Make them feel that you really is a part of their need.
Yes.
Because even if you cannot help, if you give them a patient hearing, I think that satisfaction itself is quite immense feeling in their mindset, number one. And number two, as I said, going by the history, if you can make a diagnosis, which most of us can do it, we have to explain them in simple medical terms. And as my good friends and everyone has rightly said, we are in a position to help them understanding their need. Give time. That's my question. Give them little time and make them your friends forever.
Yes, Anu, your final comments, and then we will go to female infertility. Yeah.
My final comment will be actually a non-technical point, which is actually just yesterday a patient told me they had a child after the donor sperm IUI, and they took a lot of time to decide that. And after they had a child, yesterday I spoke to them. And they told me, the female said that when I saw them in the beginning, I think 2 years back, I had said one sentence which helped them make the decision, which was I told them that by the time I had completed, I think 10 years in IVF, and I told them that in my 10 years, I have never seen anyone cry after they have a child in their lap. When actually the child comes in the lab, they forget how they achieved it. So donation is in the first step, but then you carry the baby for 9 months, then you deliver the baby, and there's a lot of parenthood in those two steps, not just and she was telling me that I said that, so I said I'm going to say this to everyone now. And she said that donation is shouldn't be taken as a very big thing, because she told me that I said that if I cross the road and I have an accident, am I going to be asked that do I take the blood donation? No, they're just going to push someone's blood in my vein. And
Yeah, I think Anu's net has gone down. So she was trying to tell you a very, very valid point, that we should not be judgmental, give them the options and let them decide. So now I hand over to Jyoti for conducting a case discussion on female infertility. Jyoti, floor is all yours.
Thank you so much, Dr. Lakshmi, and thank you for stimulating the whole panel so very nicely. And the elephant in the room has already been tackled. So now the easy part, the female infertility, is left to me. So thank you so much, and thank you all the panelists for tackling the male infertility so very coolly. So coming on now to a couple that walks to us, a very common scenario that we normally get. 30-year-old lady, she is teacher by occupation, have been married for 2.5 years. Now the husband is in merchant navy, and he has come on holidays. He is 34-year-old. He's a smoker. He's a social drinker, and now he feels okay. It is time to make a family, extend the family. So though both my speakers, they have been wonderful, Dr. Ruma and Dr. Gulam sir, absolutely crystal clear messages have been conveyed by you all. And so we will not go into the theory part of it, but still, I mean, Dr. Manoj, when this couple walks to us, are you bothered about the age of the partner? As Dr. Gulam suggested, and he showed us a lot of things in his presentation about the age, because normally in our scenario, we are always focused on the female age. We are always bothered about that. Are we ever bothered about the male age? That is one. And moreover, what all, normally we focus on the female history. Do you focus as well on the male history, and what all?
Yeah, when a couple visits us for the first time, I think for in my own practice, first of all, I try to isolate them. First, check the male, then go for the female, because there are a lot of invasive other tests and so much social and other burden on the female. So I always try to first look at the male, and as compared to the female, male age doesn't matter much, but still, when he comes, I would like to do the first semen analysis and take general history from the male, any past surgical history or medical history or any injury or history of mumps or arthritis in the childhood, things like this. First, I would like to screen male and then move on to the female.
Okay, thank you. Dr. Mangala, what all in the female would you focus here? Because they've come to you casually. This is the first visit. You are the first person they have come to. And how much would you like to talk to them here? Dr. Mangala, are you there?
Jyoti, Dr. Mangala is not here. Other 5 panelists are here. Yeah.
Then Dr. Shaili, what would you like to stress upon? What all would you like to extract from this lady now in the history? Anything specific? Very important point. That is all.
Yes, ma'am. It is the first and foremost the history of the menstrual history, whether she is having the regular menses or not, because it itself tells us that is there any anovulated factor or not. Then any surgery in the past, any pelvic surgery or any abdominal surgery, then any surgery regarding the STIs or PIDs in the past, which can get us to the conclusion of some probable diagnosis. And beside this, the lifestyle factors, whether it is smoking, because nowadays it's very common. And the affluent society also, it is very common. So these are the things which we should focus on in history taking itself. And then an examination, the age of the patient, we have to ask, and then the weight of the patient, what is the BMI, what is the habitus of the patient, are there any signs of hyperandrogenism, like thyroid disorders, any history of thyroid disorders, or any sign symptoms suggestive of thyroid disorder in the patient herself.
Yeah, so actually in this, because the husband is, so history of sexual history and the history of cohabitation, that is very, very important here, because they have, being in the profession of merchant army, navy, he has been very infrequently coming to meeting,
Yes.
having
Yes.
so that is very
important. Coitus history is very important.
Yeah, these days, because of the couples working, somebody not, their cohabitation histories, which we don't take so seriously. So that is one important thing we wanted to highlight through this case. Dr. Rathi sir, what all tests we have enumerated in the mail also? So what 1, 2, 3, 4 tests would you like to advise for the male, just on their first visit?
For the male, ma'am. I would like to go back for a few things, that since this is the first visit of a couple, and the person is from a merchant navy, usually they have a working pattern of 6 months on the ship and 6 months at home, or 3 months on the ship and 3 months at home. So this needs to be kept in mind, that for 2.5 years of their marital life, how long he was here, and then whether the couple was very keen to have a baby in their first few years of married life. So many times the couple decide that first 1 or 2 years they don't want to have a child, and then they decide, and then straight away they visit the doctor rather than trying on their own naturally. So that is very vital, that how long they have been trying actively. Secondly, when a husband visits only for 3 months, then he has to do some social visits also. In that, how frequently they are having relations. So thrice a week or 4 times a week is also, that frequency of coitus is very important. And in investigations part, if semen analysis, if first report is normal, then perfectly fine. Then then you do not have to repeat it. Second is like sugars, like fasting PP, any history of diabetes in the family, and any history of exposure. I mean, as a male, we are very frankly asking the males also when we examine them, that is there any history of exposure. So that also helps us to know whether any STD or whenever you have poor counts or motility. So that can be also addressed upon.
Right, sir. So semen test and the basic investigations you would like to order for the male, and for the female, Dr. Barua sir, what exactly would you outline at this particular first visit? Dr. Arun Barua sir is, I think, not logged in. So maybe Dr. Himangi. Dr. Himangi, what all would you like to order on this first visit to her?
First of all, the hormonal profile like LH, FSH, TSH, prolactin. Then we can go for a FSH. So we have done. Then we go for a transvaginal scan to look for the presence of follicles. As it is the first visit, if it is day 2 or 3, then we can advise the serum estradiol levels and FSH on day 2 also. And then we'll go for a anti-Mullerian hormone and follicles level, state of the follicles in the TVS scan.
Yeah, Dr. Shelley, what do you do routinely AMH, FSH and all in your practice right on the first visit, or would you like to see and wait, or because she's 30 and maybe 2.5 years of marriage, what would you like to do?
Yes, ma'am. Basically, if the patient is having regular menses and she's below 30 years, I do not recommend these tests routinely. But as in this particular case, her husband is living outside the country and she's reaching 30. And for the last 2.5 years, maybe it is due to the infrequent coitus, they are having this problem. But in this particular case, I would like to do this AMH test to assess what is the ovarian reserve. And if we give any treatment, what will be the responsiveness of ovary to that treatment. So in this particular case, I would like to do this test.
So what do you say?
And one thing more, ma'am, I would like to add. Ma'am, I would also advise an HSG to the patient for the tubal status.
Yeah,
on
so
day 7.
that we will ask. So I was just asking about you the lab test, the hormonal assays, what you would like to do in this particular case.
In this particular case, the thyroid hormone. And then if it is if she's having regular menses or it's any problem in the menses.
So the menses are 35-40 days. So
okay.
They are a little irregular.
Okay. So in this case, thyroid and then prolactin level, and then the day 3 FSS also, I would like to do in this case also. And then the serum AMH, which can be done at any time of the cycle. And then also a TVS scan, on initial scan, that the basal scan to look for what is the interfollicle count and what is the morphology of the ovaries and the uterus itself.
Yeah, Dr. Manoj, what is the importance of day 2 FSH, E2? Do you do it routinely? Do you do day 2 progesterone and LH? So what all you do and why do you do? And what is their relevance?
As we are discussing on the first visit, first I would like to do the TVS. I would like to see how many follicles are there, what's the status of the uterus, if there are any fibroids or anything. Yeah, and coming back to this question of day 2, yeah, I routinely do FSH LH on the day 2, so that I can know the status, how her ovaries functioning, and I would also like to take proper history, how cycles are there, whether they are regular and things like that.
So, and AMH, what you would want to do? Would you like to do AMH in all, or you would like to do only in certain cases? And FSH, would you like to do in each and every, or
AMH not in initial visit, like even TVS will give a very fair, good picture of the number of follicles and things like that. But yeah, when I'm planning for IVF or something, then AMH definitely, I will correlate the age, AFC count and AMH. So that will help me to counsel the patient regarding her expectations and things like that.
Yeah, Dr. Rathi sir, can you highlight more about AMH? I mean, what is the vis-a-vis FSH about the variability and all for the benefit of the people who have joined us? I mean, does
Uh,
AMH vary, and what is the advantage of doing AMH over FSH, or what exactly? I mean, what are the if we compare the two? Can we
uh,
can we compare, or there is no role of?
no, no. I mean, AMH is a robust test. It is patient friendly. You can do it any time of the day. So any time of the cycle actually. So I would rely more on AMH than FSH, because FSH in today's scenario gives me a clue of that there is a problem when the problem has already occurred. While AMH is going to tell me the same thing maybe 2 or 3 years prior to whether she is going down with her ovarian reserve. So AMH is the right investigation I would prefer rather than FSH. Secondly, in a first visit, I mean, no to all the hormonal investigation other than TSH and prolactin, because this is from a good class of patient, but a good transvaginal scan. And if I have to do only one scan, then I would prefer to call them between 8th to 12th day of the cycle, wherein I can look at the ovary, whether there is a spontaneous ovulation happening, whether there's a dominant follicle, how is the endometrium which has responded to that dominant follicle, is there any polyp and a fibroid. So all the information, maximum information can be gathered if you do a scan somewhere around day 8 to day 12, and that will help me to remove majority of the investigations, because if I am able to see a good ovarian reserve, that antral follicle between 5 to 10 in each ovary, a dominant follicle, triple line endometrium more than 7.58, then I need not have to have an ovarian reserve investigation. I would rather have only TSH and prolactin.
Yeah, Dr. Barua sir, what would your take on whether you would like to do FSH or you would prefer AMH in these cases on day 2? What would you prefer? Barua sir, your personal choice
Yes.
of test in these cases on day 2.
I'm sorry that I just lost a connection in between, so I had to reconnect myself from a different device. Anyway, just get going with the case history. What I'd like to do is, I'm comfortable with AMS, but I'll always try to look at the antral follicle count. I think antral follicle count to me is a much better test in comparison to AMH alone, because I know this test, which is a very robust test, AMH, but yet it has to be standardized across the globe. So the fallacy exists. At the same time, if you are doing an AFC perfectly and combining these two will give you a good standing of yourself about the patient's ovulatory reserve. I think having two dimensions taken up along with the history will guide you for a better line of treatment of ovulatory dysfunction, whether it exists or it is not existing.
Okay. So, and what about E2? How do you like it doing? How frequently do you do? And what is the importance of doing a E2 level?
E2, I do not do it on a routine basis until and unless this is an IVF cycle. Otherwise, for a routine take for a gynecologist who is doing a basic infertility, I think E2 estimation really doesn't give them much.
Okay. So coming on, once we've covered up, we are done with the test. Now we think about the tubes. So Dr. Himangi, what would your favorite thing would be to assess the tubes? What would you choose? Which test?
I would like to go for HSG first to assess the patency. So saline infusion sonography would be better as far as I feel, but in many setups, HSG is preferred. So I would like to go for HSG first and see the site of occlusion, whatever, how are the tubes, how is the spillage and all. I would prefer HSG.
Okay. Anybody else would like to differ from Dr. Himangi?
There are three methods basically to know the patency of the tubes: HSG or saline salpingography or saline sonography, and then third is laparoscopy. So HSG is definitely cheap and cost effective, and it will give a lot of information. But when we are doing laparoscopy, at the same time, if there are other conditions associated with it, we can treat those part also. If there's endometriosis, if there's a femoral block or something, we can do it at sitting. And as far as saline sonography is concerned, just tell us whether the tubes are. We are unable to know which side of tube is blocked. We just see the fluid, in the sonography. So it's good for on a OPD basis, but patient is willing and ready to pay, then I think laparoscopy also a good option.
Normally, Dr. Manoj, initially, I mean, patients do not like to go for laparoscopy. When we want to do the patency test, like they do not.
So HSG is a good. HSG
So,
definitely a
what
good.
are the pitfalls in HSG? Do you do yourself, or you go send the patient to the lab? And what are what are the pitfalls that a HSG has? The sensitivity, the specificity, vis-a-vis
Yeah,
the modalities.
Yeah. So incidentally, my wife is a radiologist, so we have got the access. Same. So we do ourselves here. Yeah, there is a chances of sensitivity is there. Patients at times feel pain also, though we give the NSAIDs before doing it and antibiotics before going for HSG. But these two are things are definitely a part. Patient discomfort and pain, they get at times I've seen they carry a very negative experience of these things. Otherwise, it's perfectly.
Dr. Shelley, would you like to do HSG yourself? And what is the intravasation? So many times we are talking and how we can prevent it. What is exactly intravasation?
Yes, ma'am. Like I work in a medical college, we have the radiology department, but we ourselves or our resident go for this dye injection there. So before sending the patient for the HSG, we do a PS. If there is any sign of obvious infection, we treat it first. And then at the time of HSG, we give a pre-medication with antispasmodic to the patient itself. And we just counsel them कि थोड़ा दर्द होगा, because this counseling is very important. If you do not counsel the patient कि क्या होगा, just tell the procedure in a brief, so she will be better tolerate the procedure.
And in fact, it has the way we have to do a cervical traction, make the uterus.
Now we have a very flexible cannulas also.
Yeah,
it is not in our setup, but in private setup it is available. We do it with the Rubens cannula.
How we can, why intravasation occurs, if anybody can highlight that, and how to prevent intravasation. If Dr. Rathi sir, if you have any.
Intravasation is usually because when you cannulate the cervix, if you're when you are screwing that cannula, if part of that tip is going into the musculature of the cervix, then usually that is one common reason, because when you are injecting the dye under pressure, the vessels can take up, because whenever the force is applied, when your cannula pressure goes above the intrauterine pressure, that is more than 100 mm, then the dye is pushed into the circulation because of the piston pressure which we give. One reason. Secondly, if you have a tubal blockage, because when you are pushing it, if the tubes are blocked, the intrauterine pressure is going to go up, that dye is going to go in the vessel, and you will have the intravasation. Secondly, if the cannula is too loose, then the dye would spill out into the vagina, and then you may have a faulty procedure. Going back to your previous question, madam, where you asked about the sensitivity and specificity, the HSG has the poorest of sensitivity and specificity. Sensitivity to the tune of 32% and specificity to the tune of 35%. But if you go and compare it with sonosalpingogram, it has the tune of almost 90 to 92% of sensitivity and specificity. But it is with the there is an inter-observer variation. People who are having good experience are able to pick up the tubal mucosal pattern, the dye, and the femoral movement, and then able to guide whether it's a freely floating fimbria and all. The sensitivity and specificity of an endoscopy, that is histro and lapro combined together, is to the tune of almost 95 to 98%. So if we go by accuracy, then endoscopic route is the right way, wherein you are able to pick up the other pathologies and treat well. So at one go, it becomes diagnostic as well as therapeutic. While all these procedures are only diagnostic, and for therapeutic intervention, you need to go back to endoscopy.
So let's say, Barwa sir, the patient agrees for laparoscopy. So what all, I mean, how do you counsel her? What all do you talk to her, and what does she make out of it? And secondly, any other things like the drilling and all, do you need to do? What all you specifically talk to them? And the second part is hysteroscopy. Would you like to do a hystero along with it, or just a laparoscopy there?
All said and done, when you're planning for a laparohysteroscopy, as the name says, I think I'd always like to combine both and give the maximum advantage to the patient. And I'll always prefer it within the first 10 days, though it has a disadvantage of not picking up any signs of ovulation in that particular immediate cycle. But obviously, we can get some luteal tissue seen from the previous cycle. Now, my take of doing it in the first half of the cycle, a hysteroscopy is we'll be able to see and cannulate the tubes even if it is required, not taking up this procedure on a subsequent date if we feel it was required then. And the free tube testing can also be done. We can see the dynamic activity of the fallopian tube when you do it under anesthesia, the chromopertubation. At the same time, we must counsel the patient that if there is associated endometriosis, we like to take up in one go itself, not only making simply a diagnosis of endometriosis and leaving it behind for a medical treatment. Because we all know now that endometriosis, whenever we are into the abdomen, needs to be taken in totality. And that particular advantage should always be given to the patient. So additional surgeries is always a possibility when you take up a patient for diagnostic laparoscopy and hysteroscopy. And this must be counseled and well consented from the couple before you take them to the theater. At the same time, as you said, whether the drilling, I think drilling today has been pushed back because of its misuse and disuse. But being an experienced laparoscopic surgeon, if you feel that your punctures do justify to the patient, yes, go for the way you feel like, but it's not to be burned into totally because it will be doing more harm than doing anything good. Because we have seen quite a few ovaries being punctured, maybe 4 punctures for 4 seconds with 4 watts, will be much beneficial to the patient than giving them a lot of stimulation. So it all has to be judicious, time-based, and appropriate finding that you get in a laparoscopy, but never fail to do a hysteroscopy at the same sitting because the advantage has to go to the patient by all counts.
Here, I would like to rope in our international expert regarding. Hi, Dr. Anu. Welcome to the this webinar. We are highly pleased to have you here, and I would like to have your comments here. Whether you would like to have both together, laparo histro. What does the evidence say? What are the guidelines? And maybe other comments that you would like to make about whatever we have discussed till now, because we have another 7 more minutes and we can discuss few more things after your comments.
Hello, Dr. Jyoti. How are you doing? Thank you for having me, and very, very glad to be amidst all of you very, very highly learned colleagues. Just as a disclaimer, when you started this, I missed the connection, and I wanted to confirm, Dr. Jyoti, if you're hearing me, that this is about the first visit evaluation, right?
Exactly. Actually, the couple have just started planning. The lady is 30, the male is 34. He's a merchant navy by profession. And they've just come casually talking about the family planning. So what all investigations? And incidentally, actually now that in the latter part, we'll discuss that she turns out to be anovulatory because her cycles are around 35, 40. So maybe we'll discuss about that.
But before that, we are just evaluating. So what is the active married life? Active
2.5
sexual
years.
life?
2.5 years.
2.5. Okay. So yeah, definitely I will evaluate tubes, but before that, so like I will tell the patients that 2 years or anything more, meaning that we first of all have to have a series of visits and we have to address it, and it cannot be casual anymore, because 2 years should give an ample chance for them to conceive. And if that has not happened, I will evaluate the uterus, the tubes, the semen analysis, and the blood test. So tubes definitely is one of the parts, and for that my favorite way to evaluate is HyCoSy. So HyCoSy, basically we use the water-based foam and do a 3D scan. So 3D scan is very, very central. I try to do 3D scan. So this NHS unit works differently, but when I'm in private section, I do 3D scan of every patient myself. And then if there is an evaluation for tubes to be done, I do the HyCoSy after that. So it's a one visit to do everything. They give the samples, they do the 3D, and if they consent to do the HyCoSy, I do the HyCoSy, and then there's a scheduling for the semen analysis. So why HyCoSy? First of all, it's less painful. There is no oil-based contrast, and it's a very functional evaluation and very, very easy. And pain is a very important part, so I don't want to create too much pain for any patient. So the first thing is HyCoSy, but some patients do go for HSG, for example, they already have done it. Now, before even I evaluate tubes, I actually tell them that there is a place for not evaluation of tubes as well. So if the patient has never had any sexually transmitted infection, or never had any laparoscopic surgery, or never had any other reason for which I doubt the tubes should be closed, then I give that option to the patients to just start the treatment maybe by doing one IUI or any other evaluation, although IUI has no role, I think, after 2 years. So I tell them that you do have the option to jump into the treatment without doing that, but I will not do the laparoscopy only to evaluate tubes, never, unless there is another reason to do a laparoscopy, although it is very, very close to 100%, but just to check the tubes, I wouldn't tell them to do a laparoscopy.
Which particular cases would you straight in going for laparoscopy? Laparoscopy.
And diagnostic laparoscopy is very much a patient's choice after 2.5 years. So if I see everything and everything is normal, I wouldn't really tell them that this is, so if I will tell them the statistics that, okay, if you do the diagnostic, actually recently I had a daughter of India's very, very superstar gynecologist, and she is here in London, and she came, and she had tried for over just less than a year, but they were worried because of the age. So I did HyCoSy, and she had a baby boy just recently. So only HyCoSy just flushed out the tubes maybe, and she had a spontaneous natural pregnancy.
Yeah.
So there is a role, but HSG is not really my favorite, but I wouldn't do laparoscopy only to check tubes patency. And diagnostic laparoscopy is having a place, but to be honest, very limited. If there is 2.5 years and everything is normal in the evaluation of blood test and semen analysis and tubal patency, I will directly do IVF.
So surgery has to be deferred. I mean, in case we don't suspect anything on ultrasound or on HSG, if we see tubal spasm, and if we want to confirm that, then only we go for a laparoscopy. And otherwise, I mean, it should be the second line for the manage, though it is a gold standard to diagnose the patency of the tube.
I want to add one point here. In the rural setup in India, where patients are poor, and I don't expect them to come to me for regular scans or to do IVF more than one attempt, for that patient, especially in the case of a proven known case of PCO, for example, in that patient, I will do diagnostic laparoscopy. And in that lean PCO, poor rural area patient who is not going to come to me regularly or even do IVF, for that patient, there is a place for very judicious drilling. Because
I
that will
really don't
help
know
her
what.
ovulate on her own. And even if she doesn't come to me, she might get pregnant on her own because she will start ovulating. Obviously, I'll do the ovarian testing before the drilling. Yeah.
I really don't know the reason, but I've seen that HSG more common in India and Hycosi is very, very popular in UK. So
I
most of
want
the
you all to
gynecologists.
start Hycosi.
Yeah, I mean, just train. I'm saying the gynecologists are very like.
I'm happy to
Hycosi
come
is
and
their
do a
favorite in
workshop.
UK. Yeah.
I'm happy to come and do a Hycosi workshop.
We'll do a
But-
webinar on Hycosi.
Yeah, in general, I'm saying that India, like most of the gynecologists are preferring HSG, but in UK, Hycosi is the first choice.
Although we do HSG here as well, but I don't
Yeah.
think that makes sense when we have Hycosi.
Dr. Rathi sir, Dr. Barwa sir, Dr. Himangi, anybody doing Hycosi here?
No.
Any of you? No. So we still have to maybe change our practice. Maybe once we start doing it, we get more comfortable.
Actually, there is a new name for Hycosi, which is Hyphosi, because it is the foam used in that.
Okay. So another 3 minutes left for us to shut down our platform. So now this patient, I would like somebody to talk about the ovulation prediction kits. So LH kits and all, if anybody would like to take that, because this patient now doesn't want to come to hospital, but she wants to at least try doing ovulation test, whether she's ovulatory or not. So if we can help her in that way. Anybody doing LH, or how do we predict ovulation in her?
I mean, particularly patients who are young, having regular cycles, and they don't want to go for an active treatment. This is something which they can follow in natural cycles, wherein from day 10 and onwards, they can do daily LH and look at the card. Whenever they get the second line as red, dark red, there is a on the card, on the packet itself, the details are given as, when it is to be considered as positive. And next 2 or 3 days, they can have regular intercourse, planned relations. And in these kind of trial, they can do it for 3 to 4 cycles. And if they don't achieve pregnancy, report back to the clinic. And it won't be useful for patients who are having irregular cycles.
Anything more, Dr. Shelley? Do you advise in your practice ovulation detection by LH kits in your practice? Do you use the ultrasound, or how do you go about it?
If the patient, I have told you, I work in a medical college. It is the clientele we deal. It is from the lower class of the society. They're not very educated. They are not up to that much of intellect. So in these patients, whenever we do the ovulation studies, we rely on the TVS itself. But if we are getting the patient who can understand what they have to do, then we can use these LH kits, urine sample they can do at home, and especially at the evening time, like between 4 to 8 p.m. we ask them to do. And whenever they have the first positive test, it means they are going to ovulate within next 14 to 16 hours. So we advise them to time intercourse on the very next day and day after to that day.
Okay,
to get the best results.
The LH in the second urine morning sample rather than the first sample around maybe 11 or so, and that is the time they do it, and they do it till that time it is positive, and the day it is positive after the next day onward, because then is the LH surge, and then they have to start trying. So, Dr. Himangi, now if it is anovulatory, would you like to start her on some medical treatment, some lifestyle thing or anything, or what would you do? Any advices for her now?
Lifestyle modifications should be done. They should be advised proper physical exercise and weight reduction, and they do not skip meals, and the smoking should be stopped. Alcohol, everything like that. Caffeine intake should be restricted. And they should take more monounsaturated fats instead of trans fats and all, and high fiber diet. And medications, among the medications, we should first of all look for the cause of anovulation. If it turns out to be PCOS like, then we can start on metformin. At least metformin can be started till we know the exact state of what is the thing behind. And for ovulation induction, we can start with clomiphene citrate for first 3 cycles.
Dr. Rathi sir,
And dietary, we should increase the protein and all.
Okay. And what is your choice of ovulation induction agent, everybody, whether it is clomiphene or it is like aromatase inhibitor?
In PCOS, Letros, others, clomiphene citrate.
Yes.
Okay. So basically still the first line of drug is clomiphene citrate.
Yes.
If it's not a PCOS.
In except PCOS.
Except PCOS.
Dr. Anu, your take on it? How do you go about it?
So in many units, especially in the good private units in London, the SOP of the clinic says the first line is letrozole after informing the patient that this is off license for this purpose. Despite of the, this became very popular because of the Richard Legros's paper, which said that letrozole is drastically better. In 2014, Cochrane published a review of RCTs, which said which was in favor of letrozole, but so all the SOPs were based on that and Dr. Richard Legros's work. But the same group of Cochrane in 2018 reviewed their own review done earlier. And this time they took off all those studies which were not very good standard studies. And then they did the analysis again of the RCTs, which were only good quality RCTs. And the conclusion was updated in 2018, which said that both are equivalent. But the SOPs were already made and people were already giving talks in the conferences in favor of letrozole, and their talks were being liked because something is better than the old drug. But I think, I totally agree with Dr. Arun Rathi's points today, very rightly. So CC and letrozole both can be given to a non-PCO group of patients. Letrozole, we have to tell them it is off license for this purpose. It's not an approved drug for this purpose. And in PCO patients, okay, there's a marginal benefit maybe in favor of monofollicle, which is actually not accepted in the 2018 review of Cochrane. So actually the monofollicular development kind of a concept is refuted by themselves. So I would say CC has a very good space in this as an ovulogen, and I will definitely use it for someone who leaves the decision on me, rather than I can always give a choice to the patient. Mostly they choose based on what they want, but if they ask me to guide, I will guide in favor of CC in many patients, and a few patients letrozole. In my private sector colleagues, most of them, what are they doing? Just to tell you, they are using letrozole as a first line.
Okay, so thank you so much. Thank you, Dr. Anu, for making us know what you guys are doing there. And obviously, this is actually the aim of doing this Indo international series, so that we have no limits now. We are all together in the same seat, on the same platform, on the same page. So,
Dr. Jyoti, I feel I'm more present in India now than I actually was.
Absolutely, absolutely. Thank you, and thanks to Corona actually, because of which we are actually seeing each other at the same platform. No boundaries, no international boundaries now. Dr. Lakshmi ma'am, I think we have already crossed our time. So over to you now.
Yeah. No. Just a minute.
I am being Dr. Lakshmi Srikhande today on the, I think my
Yeah,
name
yeah.
is flashed.
I told you so many times to please rename,
I
but
don't
you
know
have
how
not
to do
read
it.
my chat. No,
I don't know how the name. I was seeing my name is coming as Lakshmi Srikhande.
Yes, seeing for Dr.
I don't mind. It's a lovely name to adopt.
Thank you so much. And
Dr. Lakshmi Srikande's name is there on 4 platforms there.
Because you are not bothered to rename yourself. So I invite Ritu.
Yeah,
to
no,
proceed.
not
We have
mine.
already overshot our time. So please proceed. And on my behalf, I would like to thank Anu, Dr. Gulam Bahadur, Dr. Uma, and especially Dr. Ritu Khanna for being such a wonderful MOC and spending your 3 hours on Saturday afternoon for me. Thank you so much, Ritu. And I also thank all the esteemed chairpersons, faculties, and panelists. Yeah,
Thank you so much, ma'am.
propose official vote of thanks. Yeah, so Ritu, please invite Jyoti.
Yeah, thank you so much, Lakshmi ma'am and Jyoti ma'am. It was really an innovative panel, and Dr. Anu has given really such valuable inputs, and being on that international and Indian forum, I think it was a great discussion. And all the panelists, Dr. Arun Sir Square and Dr. Manoj and Shelly and also Himangi, I think we had a wonderful, wonderful discussion. And thank you so much, all the learned panelists, experts, and the moderators. And with this, I hand over to Dr. Jyoti for the vote of thanks.
Yeah, thank you, Dr. Ritu. In fact, this is the first venture of Indo International Series that has been executed by Dr. Lakshmi ma'am. In fact, I conceptualized it, I asked her, and she did it. So that is
it's a team effort, it's a teamwork, and I am really happy that it went off so well.
And many thanks to Dr. Jyotsna Pundir, our international coordinator, and our national coordinator, Dr. Sushma Verma ma'am. So absolutely, with your coordination, we have been able to achieve it. Our chairpersons, Dr. Rekha ma'am, Dr. Famida Banu ma'am, Dr. Tripura Sundari ma'am, and Dr. Sushma, you have in fact gave so much small inputs to the talks that our speakers, our international speakers, Dr. Ruma Bhargava and Dr. Gulam Bahadur's talks, which we all speculated, and we have been, they were absolutely crystal clear, wonderful, and worth attending today's session with these 2 international speakers on the floor. And what to say about our international expert, Dr. Anu, she has given us great input and has shown us what differently they do and what we may try on our aspect. Our panelists, Dr. Manoj Chirani, Dr. Mangala Dosh could not join us. Dr. Arun Rathi sir, Dr. Barua sir, Dr. Shaili, Dr. Himangi, and all the panelists. Actually, it was a panel more of like evidence without any people. It was a one-to-one seeing you, talking to you, and listening to you. And I emotionally thank you so much for doing the whole bit right from the beginning till the end. And Walter Bushnell, thanks a lot. And what to say about our Dr. Lakshmi, many thanks for giving me this opportunity. It is absolutely a learning experience to always be working with you and to learn from you. Thank you so much. So
I would like to say one thing, ma'am. I am a fan of Dr. Anu Chawla. I am following her on the Facebook. She's such a beautiful, so beautiful. And life
You are so beautiful. Oh, thank you so much.
So that is why she's blushing now, Dr. Shail. So we meet again, ma'am, Dr. Lakshmi ma'am, we meet again on 25th with our second webinar, Sunday, 25th July.
Dr. Lakshmi?
We keep meeting regularly, so please wait for our further announcement, and thank you so much. Bye.
Thank you so much, ma'am, for giving me the opportunity and pouring us with complete knowledge about the male and female infertility. Thank you so much, ma'am. Thank you so much, all the esteemed faculties. Thank you, ma'am.
Bye. Good night.
Good night, ma'am.
See you again. Bye.
Thank you, Dr. Lakshmi, for the opportunity. Well conducted, Dr. Jyoti and Dr. Ritu Khanna. Thank you all. Bye. See you again.
Thank you, ma'am.
Yeah.
Thank you, Jyotsna. Thank you. Bye-bye.
Bye. 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 Thank you.
अपने पहले क्यों नहीं दिखाई तो ठीक आया, नॉर्मल आया। तो आज की पर्ची में सर से नहीं लिखवा लेती दवा?
नहीं लिखूंगी, जाओ से 5 से बोल दिया।
अरे
हाँ, उसी ने जैसे अगर कोई नॉर्मल आया है उसी पास जाओ, लिख देंगे वो लोग ऐसे। सुबह से आए मैडम, पानी 5 बजे डॉक्टर है।
मैं छोड़ दे।
ये धड़कन कैसे बढ़ सकती है?
तुम्हारा सुनो रखना।
पेशेंट के पास, हाँ सुनो रखना। पेशेंट को देखो।
रिकवरी में ले लूं। पटेल सर आएंगे। सीमा को बोल दो बैठ के। और आर्टिफिशियल भी करा ले रहा उसका।
हार्ट वार्ट कुछ परेशानी नहीं है?
नहीं, अब तुम्हारा सब तो करा लिए है अपन।
नहीं, हार्ट में थोड़ा परेशानी।
नहीं,
धड़कन दर्द से बढ़ रहा है।
तुम सोचती ज्यादा हो, सोचना बंद करो।
कोई मर गया, बोलते था धड़कन बढ़ रही है, कोई झगड़ा करने वाला है, बोलते था धड़कन बढ़ रही है।
नहीं, मत सोचो ज्यादा, जो होगा देखा जाएगा, ऐसा टाइप का सोचो।
ये पाम है ना, पूरा झुंझुनी है।
नहीं, उसके लिए मैं लिख दूंगी।
हाँ,
उसके लिए मैं लिख दूंगी।
जैसे ना जंगली में चिपका कैसे लगता है,
झुंझुनी के लिए लिख दूंगी।
यहाँ तक चढ़ जाते पूरा एकदम छोटा लगता है, जैसे सुनने होंगे जैसे एकदम ठंडा ही फील होता है पूरा। और उसे मैडम से अपना दवाई मालूम किया था, कमजोरी के स्कूल में कुछ खड़ा होगा ना, हिला तो ऐसे बात काट नाम से। और सुबह सो उठता ना, 1-2 घंटा चक्कर तक चेक लगता, नसा नसा खाली पैर को चले नहीं जानते, एकदम कोठो लगता है, अच्छा नहीं लगता खाली पैर चलता। पूरे तरह से हाथ मैडम तो पूरे तरह था, जान पर जान तो नहीं है।
नहीं, दवा तो दे ही रहे हैं तुमको।
बाटा लोटा चढ़ा के पर
बॉटल चढ़ाने से नहीं होगा कुछ। बॉटल तो उनको दी जाती है जिनको कुछ ऐसे वो आ गया बड़ी।
जैसे पन्नी में बाटा चढ़ा है, 2-3 बाटा आदत थोड़ी ना आप कुछ सोने के लिए
लैपटॉप से
हाजी
चल दे लैपटॉप।
ना दे देना, आबड़ा कैसे लगता एकदम बुलाया नहीं, कैमरा लगा देख लो।
उसका ना रोशन को बोलना भी कभी के पास टेम्परेचर ले ले, जल्दी बोलना उसको, रोशन ही लेगा। रोशन है
आप ऐसे खड़ा तो खाने नहीं।
नहीं, वो तुम्हारे मन को दूर करने के लिए मैं कराई हूँ, मेरे को नहीं जरूरत थी। मैं तो तुमको पहले ही बोली थी कि ईसीजी नॉर्मल है तुम्हारा, ईसीजी नॉर्मल है। तुम बोलती थी इसलिए मैं करा।
अब टेंशन
कि भाई हार्ट में कुछ नहीं, तुमको लगता था कि तुमको हार्ट अटैक आ सकता है, कुछ हो जाएगा, है ना?
मुझे खाना नहीं पैसे।
हार्ट का कुछ भी नहीं है तुम्हारे को, ये तो मैं तुमको बता ही सकती हूँ ना कि अब तुम्हारा हार्ट एकदम नॉर्मल है। और छोटे मोटे नहीं, पूरा जो दिल के डॉक्टर है एमसीएच के है, उनसे दिखवाया मैंने।
बिलासपुर का हार्ट में प्रॉब्लम ऐसे बोल रही है?
नहीं, हार्ट में नहीं है प्रॉब्लम। हार्ट में ना तुम्हारे एक्सरे में प्रॉब्लम थी, ना ईको में प्रॉब्लम, ना तुम्हारे एक्सरे में प्रॉब्लम, ना तुम्हारे खून जांच में बहुत प्रॉब्लम। आधा डर तुम्हारे मन में। मन से निकालो चीजों को, ठीक है? बाकी तुम्हारा कोई भी रिपोर्ट इतना खराब आएगी नहीं। गैस का शिकायत है?
अच्छा है ना?
अच्छा है, सोनोग्राफी नॉर्मल है, मिर्ची मसाला थायराइड का रिपोर्ट नॉर्मल है, मिर्ची मसाला खट्टा खाने मना की
नहीं खाता।
बस इतना ही ध्यान रखना है कि फल खाना है, अंडा खाना है, मिर्ची मसाला खट्टा नहीं खाना, और काम करो, थको और सो, ना कि आराम करो और सोचते रहो कि क्या हो गया क्या हो गया।
सही बात है,
नहीं नहीं मत करो, सब कुछ है ही नहीं तुमको। अभी से तुम ऐसे रहोगे तो सही में बीमारी आएगी आज से 10 साल बाद, 20 साल बाद, जैसे उम्र के साथ आती है, तब तुम क्या करोगे?
ये तो हाथ पर कांपते हैं।
नहीं नहीं, काम करना चालू करो, तुम स्वस्थ रहोगी अगर तुम काम करोगे। 2-4 दिन दर्द देगा भी तो कुछ नहीं होता, काम करना चालू करो।
ये उंगली हुई ना पूरा थोड़ा रख एकदम शून्य से कर।
अपनी तरफ से तो मैं तुमको पहले इंजेक्शन भी लिख चुकी हूँ।
बहुत एक सलाह वाला।
अब इंजेक्शन भी नहीं लिखूंगी मैं।
ऐसे ना सांस को लगाए सीधी नहीं काम में तो फिर
नस से लगाने की आती है, लेकिन उसको ग्लूकोज में डाल के लगाना रहता है, ऐसे डायरेक्ट नहीं लगा सकते।
डॉक्टर तो से डायरेक्ट लगाते तो
वो लोग कर सकते हैं, लोग पढ़े लिखे डॉक्टर हैं, लोग ऐसा नहीं करते हैं। किससे सब बीपी पल्स टेम्परेचर ले लो तुम।
यस
अच्छे से देखने बोलना। नेहा हो तो नेहा को बोल दे, नहीं तो एरोस्कोप बोलते, कृष्णा को बोलते।
एक आध बार लगी।
हाँ ये लो, इसको रखो तुम। पल्स देखिए वो इको करा के आई। साफ कर देते तीन लोग चले जाना। नहीं आ जाएगा संडे में कोई ऑप्शन नहीं है। लड़की को आफ्टर में बुला ले, जो पड़ी रहेगा तो फर्स्ट डे पे टेम्परेचर लेके उसमें फोन कर देगी, समझा देगी, थोड़ा सा पूछ लेगी पेशेंट से, फॉलो पूछ लेगी।
हाँ वो बोली है अनीता कि मैं तुम्हें से आ जाऊंगी, तो मैं मीना दीदी चल दूंगी। आपको तनु दीदी को मना किया ना।
कल बहुत सारे पेशेंट इंजेक्शन के लिए आएंगे, फिर दिक्कत हो जाएगी।
मैं मीना दीदी और अनीता वहीं से चली जाएगी। उसके बाद में नेहा दीदी आप बताइएगा ना। कितना मॉर्निंग
मेरे को अभी इतना सारा सोचने के लिए मत डालना है। अभी दिक्कत हो रही, तेरे को दिख रहा है ना, वो गरिमा का ठिकाना नहीं। नहीं तो तेरा कब तक क्लास रहेगा भाई? मैं क्या करूं बताना। गरिमा अभी आ नहीं रही है, वो नाइट करूंगी बोल रही है लगातार। गीता भी आ नहीं रही है, मेरे पास ऑप्शन लिमिटेड रह जाता है। अनीता आएगी तो अनीता नेहा करेंगे, मेरे को तो दो ही, और सीमा तो है परमानेंट। तो अनीता नेहा करेंगे तो तेरे नहीं चाहिए मेरे को। और एक के लिए इसको फिक्स कर दे रात के लिए, इसको आफ्टर के लिए समझा दे। हाँ कम से कम थोड़ा बहुत तो पेशेंट आएंगे तो बात तो करेगी, फोन तो करेगी मेरे को, बीपी पल्स टेम्परेचर तो लेगी। इससे नहीं बनेगा तो सीनियर
मैं नाइट अभी मंडे की नहीं को देती हूं, मंडे से फिर अनीता
हाँ मतलब डिपेंड कौन कर रहा है। ठीक है
आप मेरे से इसको भी लेके जाएंगे।
मंडे को क्यों जा रहा है? मंडे को कितना मुश्किल हो जाएगा, जो एक जन आएगा उसके लिए तो हालत खराब हो जाती है। मंगलवार चले जाना तू, मंडे को हाफ डे कर ले, कम से कम मंडे हाफ डे ले ले, फिर बीच में वाले एक दिन और हाफ डे ले ले। मंडे ना तू 10 बजे आके, कितने बजे आता है अभी तू? 9:30 बजे कहाँ आ रहा हो तू आज बोला, रोज तो तुम 10 बजे खोल रहा हो मेडिसिन। उस दिन तो 10 बजे आ रहा है, तो 2-3 बार हो गया। वो 10 बजे आता है, तो आज कैसे नहीं खोला था? आज मेडिकल वो तो 10 बजे आया है, तो बोल 9:30 पे आएगा वो, 9:30 से 2 बजे तक कर लेना, ज्यादातर काम हो जाता है तब तक। और फिर बीच में क्या दिन और ले लेना। इंट्रोडक्शन आइसक्रीम दे तो यार, मिल नहीं रही है। तो कितने बार हो गया विपिन को बोलते, अभी मेरे हाथ में लाके दे। हाँ मुझसे पूछ भी लेना। सर कोई देख ओपीडी में से पूछे भी ना मत लेना, परसों काटने के पहले एकदम थक गई। ड्रॉप ऑफ ही रख, थोड़ा सा फर्स्ट पॉइंट थोड़ा पास दे दे। कितना है गलत एक पॉइंट दे देना पास। पढ़े से आएंगे तो बोलेंगे रखना है, बोलेंगे तो ले। अब हम स्टेट में लिखी हूँ मैं से कि सर फिर जैसा बोलेंगे हम स्टेट में ही समझेंगे। अगर बहुत वो नहीं लेना है तो नहीं, पेशेंट को नहीं रहेगी तो रूम में देंगे, इसको ज्यादा देर यहाँ रखना भी ठीक नहीं है, उनकी पूरी इन्फेक्ट हो जाएगी।
मिडिल जानता है को वो तो चाय के बोली कमर से दुख रखता है